Okay. Good morning, guys. All right. I do have say really quick. Um, so I handed out a lot of zeros. This morning, yesterday, the day before. And about the ATI remediation. And I just got an email from one of your peers that made me have a little bit of change of heart. Um, so here's the thing. When you get a ridiculously high score on an ATI practice test, it is very obvious to all of us that you used outside sources for that practice test. Okay. So, um, you in the wrong room, girl. So I automatically just took that very negative, I guess, in the most negative way that I could possibly take it. Meaning that you're sitting there with Chat GPT or Google or whatever, and you're just looking up these answers and answering these questions, which is truly a disservice to yourself. I don't assign it for my own, personal gain. I don't need to take them. They're for you to learn. And one of your classmates emailed me this morning and said that when she had gone to a different instructor to get help with those practice assessments, they had told her, use your resources, use your ATI books, use your books, whatever, which I think is amazing. I mean, that's amazing. What is the word I'm trying to say? Encouragement. And I do want you to look at something, realize you don't know the answer, figure out the answer, and figure out, why that is the answer. And I love that. So I guess what's hard for me, obviously, is I don't know what you're doing. You know what I mean? I don't know if you're just trying to get it done as fast as possible because you only have a small period of time, a window, because we have kids, we have families, we have work, we have lives, we have school, and we have to get XYZ done, and you're just trying to get through it as fast as possible because you're checking it off your list. Or are you taking the time to go through it and learn and build and do all the things that you need to do to succeed in this class? There's no way for me to know that, right? I'm not in your living room. I'm not in your office or in your car or wherever you're taking this test, knowing and seeing what you're doing. Okay. So this just happened, so I haven't really made a decision yet. I mean, obviously you guys will see in your feedback comment that I said, "Hey, this is an abnormally high score. If you used an outside source for this, I would appreciate that you redo it." Or I said, "Hey, this is very obvious that you used an outside source, and it's practically impossible for a student here to get a grade on the AI practice test, um, redo it." So I haven't necessarily made a decision about what I want to do about this yet. Um, I'd like some feedback. For those of
And
you, believe me, it was more than half of the class, more than half of the class that I literally gave zeros to and said redo it.
I
Um,
guess I didn't realize we weren't allowed to like use our ATI books and stuff to do it.
well, so Charlie, like I was saying, I think I was taking it in a really negative way. I wasn't taking it in like you guys were sitting there and that's my fault. That's 100% my fault. You know what I mean? I'm sitting here just thinking like you're, chat GPTing and just getting the answer and not I shouldn't have assumed is what I'm saying. I should never assume. And I always say that in nursing. If you have ever had me in clinical, which I know you haven't, but I literally tell my students constantly, don't ever assume, okay? Because assuming is the worst thing you can do. You never assume that your patient did something. You never assume that the nurse did something. You go and find out for facts without ever assuming, because when you assume, you're usually wrong. So like I said, that is my fault. That's my own, personal thing that I need to reflect on as an educator. Um, and I think it's because I just had like a cheating situation really recently that kind of maybe like tainted my feelings a little bit. So I want you to use this as an opportunity to learn as much as possible and get in there and do the work. That's what it's meant for.
I think
So,
also, I'm
so
sorry, but like even in the
no,
chat,
please go
Tiara
ahead.
said something about how some of us already took the test, which most of us have and already done remediation. So it's just like we already remember what we had to do before, if that
Okay.
makes sense.
So
Yeah.
Like,
the
and the
practice
notes from
practice
that, we
test.
already wrote from that before from our previous class. Because for me, I even have notes from last class that I already still have. Like,
Mhm.
it's just I already took the class, so it's kind of like just remembering what I put the first time that I took the test.
Right. I
But
was gonna say
So
the same thing, but I
yeah,
still took notes. If you look in my notes personally, I took notes on stuff that I felt like, even though I knew the answer because I took the test before, I still took notes on it to get a better understanding, to keep like retaining the information. That was me
right,
personally.
because we still have
I
the
still
ATI
did
test we
miss.
gotta take.
Yeah, I still
good.
did miss
I will.
a lot on mine,
I'm
even
confused.
though
Mine says
I knew majority
complete.
of the
Am I
answers.
looking for something else?
I'm sorry, say that again,
When I
Amanda.
go and look at my grade book, it says complete. Does
That's what mine
So
says too.
I
oh,
didn't fail everyone. I didn't give zeros to everyone.
okay. Yeah, I
You know
mean,
what I
like
mean?
I will also
I
say, I don't know
personally
about
took that
everybody else
test probably
specifically,
3
but
times last
Go ahead,
month.
our
Marissa.
Not last month,
our
but
last
when
class
I took it about 3
and like the
times
last
just for
Okay,
the practice.
time out. There's too many people talking. Marissa, what are you saying?
our last instructor that we had for med surg, so for the last 3 months too, she changed how we had stuff done previously, like when it came to ATI assignments. Before, if we did the ATI assignments, it was kind of complete, like you did it or you didn't. It didn't matter what you got, as long as you did the assignment and uploaded whatever, you got full
Yeah.
credit for it. So she changed it for us, and it was based off of whatever you got. And that really messed up a lot of people's grades the first time she did that, not knowing that that's how she was doing it. So then it was kind of like, well, we can't use this to our benefit to see where we're at and what our knowledge is, because we have to get a high score on this so that way it's not dragging our grade down. So I mean, I guess maybe
Who
that
did
too,
that?
like shame on me for not realizing. Miss Belay.
Okay, so that's not how it's done. And I
Yeah.
will address that with her and I'll have a conversation with her about that because your practice test A and B and your actual ATI proctored exam, all three of those are worth 10% of your grade. Right.
Okay.
So if you got and it says that in your syllabus. So, and that's why this month it's actually, and I wonder if that's why it was changed. Because going forward from now on, it is now like a complete or incomplete kind of situation, which is nice because when you take your final proctored exam, it's a lot easier to figure out your grades because that big proctored exam is actually worth 8 out of 10. Okay. 80% out of that 10, it's worth 8 out of 10 of those points of your final grade. And the practice tests are only worth 1 point each out of that 10%. Does that make sense? So when
Yeah.
it was weighted and the practice tests were in, and we were waiting for that proctored exam to go into your final grade, and then your proctored exam did go in, and then all of a sudden you lost 3%, that was a huge issue, not only for you guys, but for us, like trying to figure out, oh my God, like this person is sitting at a 78, and if they don't get a level 3 and do really, really well on this final, you're going to fail this class. So having that like false high score and then having that drop right at the end is not only detrimental to you, but also to your instructors that like have to factor in how much of a drop you're going to have even when you have a level 2. So this the way that it is now with your ATI practice test being complete for 1 point, complete for the second point, and then that proctor being that 8 out of 10%, that is the true grade that when your proctor is going in, it's not going to drop your grade significantly. Does that make sense?
Yeah. That does make
Okay.
sense. And that's a lot better and different than what we have. It's just that, you know, things are not consistent at this school. And that's been a thing, you know, throughout our time in the program. But that change was definitely like a lot to all of us. We were like, whoa, what the heck? So now we practically are being forced to use outside resources to maintain a good grade. So that way we have a little bit, because yeah, that couple percent that our assignments are worth for our grade in hindsight really doesn't look like a lot, but it can be the difference between somebody passing and failing. So we were
100%.
forced to do well and use other resources to make sure that we didn't fail based off of that.
Yeah.
So that could also be
I
another reason why
understand that.
maybe people opted to do that, which also
Yeah.
shame on us for not like reading and seeing that it was like a complete or incomplete, but that's just feedback
Well, that's
that
okay.
I thought you should know.
So, well, and that's another thing too, that, you know, again, I'm getting my master's in nursing education. My current class that I'm taking is nursing education with technology. And I work full time. I am a nursing instructor. I'm also a clinical coordinator. I'm also a mom and a wife. And I am also, you know, a person, and I have all of these things that I'm trying to balance throughout life. And then I'm also getting my master's degree, so I'm also taking classes online. And to be able to find that balance between all of the things, right? If you really think about it, if you're sitting at home, you have kids, you have a wife or a husband, you have a full-time job or a part-time job, and you also have school, we're in the same boat, you and I. You know what I'm saying? So it's important to me that as an educator, I realize the challenges that you guys are going through, just like the challenges that I'm going through. I did homework yesterday, I'm not kidding, for 6 hours. I literally was sitting, I had to take time away from my 3-year-old and my husband and put myself away in my guest room, and I had to do homework for 6 hours yesterday, and it was like, this is crazy. So I absolutely know what it's like to be in your shoes, because I'm in your shoes right now. So I think it's really important as an educator to understand the difficulties and challenges that you're facing right now. But I also want to make sure that we're all in a learning environment and that we're all taking that chance to grow and learn and not just copy paste, copy paste, copy paste just to get it done. And there's nothing I'm not psychic. I can't see through walls. So I don't know what you're doing, you know, while you're taking these exams. So I think what would be really nice and really good for me and you. I mean, a lot of you have said, I have these notes. I took these notes. I did X, Y, and Z. I did this work. Let me see it. If you are going to turn in an ATI test with a 95% with a remediation this big, and then you come back and tell me I have 10 pages of notes, you better give them to me. I want to see them. Because because that work, that's worth it. That's what's worth to me seeing that you got a 95% on an ATI practice test. I need you to prove to me that you actually did that work and you didn't just look it up. That's what I need.
Is there a time limit on their ATI practice?
Great question. I
There
don't
is,
know,
but
because
it's like
I think
8
it
hours.
was
Like 8 hours.
yeah,
Eight
it's a
hours.
lot. It's big. It's a big period of time because I
Okay,
mean
because I was gonna say
I've
I
seen
took over an
anywhere,
hour and a half to take mine, so I obviously wasn't just
which is
copy
great.
pasting. Yeah, I wasn't.
Which is
Because you said on mine this is an abnormally high score. You weren't being rude. I'm not saying you were being rude.
I
It
wasn't
was
trying to
just,
be.
no, and I got like an 86.
Yeah.
But you were like, it's an abnormally high score. I'm like, an 86, and it took me an hour and a half. What? Like,
So here's the thing, that's the thing about ATI is that when you get a 50-60% on an ATI, that is normal. That is normal. That is a normal grade for ATI. 50, 60, 70%. And I'll show you the proof of that. I literally just did a deep dive into ATI this past Thursday and Friday because my leadership students were complaining and complaining about all of the proctored exams they have to take and all the practice exams they have to take and blah, 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 and how they're not scoring good and all this. And I actually like downloaded the information from ATI itself explaining that getting a 50, 60, 70% is actually 50s is a little below average, 60 is right at that average, 70 is above average, 80 is way, way above average. So I don't want you to get a 50% on a practice exam and then be like, oh my God, I'm so stupid. Why did I don't know anything, this and that. No, that's normal. So does that make sense?
Yes.
Can I say
I
something
mean,
really
the purpose of the ATI is kind of to help get us, not necessarily have anything to do with the classwork. It's more so NCLEX prep is like
Amen.
what
Yes.
the ATI is for. So it's like, it's not even stuff that we're learning in class. So what you're saying is if you got a 95, where are the note, because you have to have some sort of notes to get to that 95%. So if you have that, show that, and then you get your grade.
right, but most of
Amen.
the
Pretty
drugs,
much
again,
just
I feel like at the
ATI.
same time are drugs of the cardiovascular system, which is something we're learning right now.
Which is great. I'm just saying I need to know that you are actually putting in the effort because that's what this is for. It is my job to make sure that when you sit and take that NCLEX, that you are ready to take that NCLEX. I have students and I understand that things have changed here. I understand that it's been frustrating for you guys and I am trying so hard to make the changes that are happening now in this program the right changes, the ones that are going to benefit you throughout in the end and it's going to benefit every class coming forward because that's why we standardized the math. That's why we changed the ATI being from complete or incomplete to and then that proctored grade not dropping you 4 percentage points. I'm really, and I know that you guys just met me, but truly it is my purpose to make sure that you are ready and be a meaningful part of your nursing journey and make sure that you are successful in the safe care that you provide for the rest of your career. Like that is my job. So
are
Go ahead.
I was just gonna say, are you looking at all of the scores
For what?
for ATI? And I'm only asking, I can only speak for myself, but if you go in and if you look at my personal practice scores, I didn't get that score on the first try. So
Oh
because
no, I honestly, I see what you upload. Because there's
right,
so many of you, I don't go into ATI and look you up individually because there's 43 of you. And that's just a lot, especially with all of the Lippincots and the ATIs and everything. So no, to be honest, I do not do that. And if you can take that practice test, there's unlimited amounts of times that you could take it.
right. I'm
So
only saying because I was one of the people, I didn't even look at my grades until you just mentioned it, but I'm one of the ones who you gave an incomplete to. I've taken this
right.
test so many times, and you can, ATI still has every single time that I took a test. So I got a 93 on the one that I submitted, which I still took notes on. However, that wasn't my first score. So if you go, like if you were to go in, because you can see it, you can actually see it on your end that my raw
Yeah.
score wasn't that 93. And of course, I'm going to know the exact question and answer because I literally just took the test. I'm going to know because I took it so many times. It's the exact same question, exact same answers, exact same rationales, everything. So
Yeah.
I'm just asking, can
So
you in mind too?
I think what's important is that you guys realize that I am also learning and growing just like you are learning and growing. And this is a really, really good learning opportunity for me as an educator. And that I appreciate and love all of the hard work that you guys are putting in. Like that means the world to me. It means everything to me. So I hope that my hope is that I obviously I want to move forward from this and I want all of us to treat this as a learning situation. And I want to see you learning and growing throughout this process so that you can be the best that you can be. So I want all of you to understand that I'm here for you 100%. Like I am always going to be here on your side, ready to help you and ready to jump in, no matter what. And I'm always going to hear you out. So, if you have those notes, I'd love to see them. And you know what? You can put in comments during when you submit your stuff too. You can even say like, "Hey Jess, I did XYZ and I worked really hard on this ATI and I spent 3 hours on it and I have all of these blah blah blah." You know what I mean? Because I understand that you're probably experiencing this for the first time with how much I care about each and every one of you and your success. And I understand if this is the first time that you've ever felt that way in this situation. So let's work together, let's grow together, and let's, move forward together because when you come into complex care 1 and 2 with me, you're already going to know what I want, what I expect, and how much I want you to learn and grow, and how much I expect you to know when you get there. Yeah. So I don't know. I don't know what else to say because I'm going on tangents now. Hold on 1 second. Go ahead.
I know after we're allowed to take it up.
What's up, Derek? I don't have any of that. Yeah, from her computer.
Oh, so it's already on her.
Yeah. Hey. They're probably the ones in Lippincott. Yeah. Sorry, go ahead. He was standing out there for like 5 minutes.
So when we did it in fundamentals, I thought we were only supposed to take it once, and that was what we were supposed to upload and remediate on. Then we could take it multiple times.
That's what I thought too.
And yeah, no, I do agree with that. I do agree that you should remediate on that first attempt because it's not really fair to everyone else if you're getting a 93 4% and your remediation is this big because you did XYZ to get there, and then you have someone that got a 55% and turns in this really great remediation because they put in all this work, that to me isn't very fair. So I do agree that I believe your remediation should be on that first lower attempt, if you're going to be that person that takes the first attempt without anything and then remediates, and then you want to take it again and get a better score and keep practicing whatever. I think that's great. If you're going to use all these outside resources and take notes during this time and you're going to give me a 95%, then and your remediation is this big, then yeah, I expect to see a lot more work from you. Does that make sense? I mean, that's just only fair, right?
I have a question, Miss
Hold on
Simmons.
a second. Go ahead.
So in ATR, they got something called quizzes.
Yeah, I love dynamic quizzing.
Taking those and Andy was confident and another person answer.
Oh, dynamic quizzing is epic. Yeah. Oh my God, yeah. Yeah, absolutely. Who was going to say something? I do want to jump into class very soon, so go ahead.
Okay, it's just really quick. So if we are redoing and resubmitting the ATI and we get a higher score because our brains might just naturally remember what was wrong, what we got wrong is, because it kind of sets a precedent like, oh, don't score high.
No. It's just I want to see some work. I want to see some progression. And it does suck that you are in this situation where you're retaking the same test and you already know the answer. Like, yeah, that sucks. Like there should be different practice tests for situations like that. So I totally understand that. If I already took a test and then I took it again and I already remember the answers because I get it, like you remember stuff, what do you expect from me? I really do get that, but is there more that you can go into about that drug or about that situation? You know what I mean? It's not all about just answering that one question. It's about progressing through knowledge and saying, okay, well, if I already know that omeprazole is a PPI and I want my patient to take it in the morning and they shouldn't take it with antacids and that's the question, then okay, I already know that. What don't I know about PPIs? What don't I know about omeprazole? What are other PPIs called? You know what I mean?
Yes, but I guess my question is, what would you like to see as far as when we redo it and resubmit it? What are you looking for?
So, Christina, I'm assuming you were one of the people that I gave a 0 to.
Uh-huh.
Okay.
Yes, ma'am.
So when you redid the exam,
Turn in the take the it
Hold
says
on.
on the sorry, but it does
Hold on.
say to just turn in the review. And I got an incomplete for not turning that piece in.
You're on mute.
Oh, well, that was just for you, June. You specifically just forgot a part of your thing. I'm talking. Christina is talking about something else. So if you are in this situation like Christina, who she took her exam, she remembered a lot of the questions, she flew, she did it, whatever. Do you have to redo it? And what do I need to see for that? For Miss Bonnie, she just told me that she redid the test, or she did it. She has all these notes, blah, blah, blah. I'd love to see them. Christina, I don't know exactly.
At the
Cool.
same time.
I don't know exactly what you did. I mean, are you telling me that you literally remember 80 questions and all the answers to those 80 questions? Is that what we're saying?
Anytime that I've taken an ATI test and I have to redo it to, in the aim of getting a higher score, I do typically remember most of the things, like the rationale of what was wrong.
I love that. I'm the same way.
I have a question.
Yeah,
So,
that's definitely, that
I
would
have a
be me.
question. So I'm
will
one
know.
of the people that had a 95. So if I retake this test, I'm gonna have an even higher score because I already took this class. So are we gonna get punished because so are we gonna get punished because we took
So
that
here's
test?
the thing. Here's the thing, Tiara. I'm not punishing any of you. Okay, that's the point that I'm trying to make, is that I'm also growing as an educator, and this is a learning experience for me and you. There is no punishment. This is an open conversation that we're having. So I really don't want you to be in a negative place talking about this, because I'm really taking this as a positive and taking it as a growing experience for myself and for you. So please try not to be in, a negative place where you're like, am I getting in trouble, or, whatever. So let me think about it. Yeah.
I'm sorry, I didn't mean to interrupt you. I had my hand raised like 20 minutes ago, so I'm just letting
I'm so
everybody
sorry.
go.
It's hard for
You're
me to
okay.
keep track of go ahead.
I turned in 7 pages and then you emailed, I got an incomplete and you put that I needed to upload my review. I went back into the file and the review is on the last page.
Oh,
So
okay. Okay.
I just wanted to clarify that because I did submit it yesterday and then I emailed you privately, like letting you know that it was submitted yesterday because I didn't want any point, you know what I mean, anything to
Yeah.
in my default.
I also have 80 emails to go through right now because I chose to do 6 hours of homework yesterday instead of
No, you're totally, I
going
understand.
through
I just
all of
didn't
my
want it to
emails.
fall back on me in a sense. That's why I was like, I submitted it like 11, 12 last night. I promise.
Yeah.
Miss Simmons,
Um,
I emailed you my chapter 47 prep you and my ATI because it would not let me submit. It kept saying it was the file was too big.
Same
yeah,
here. I did that too.
I changed it has no restrictions now. I don't know if you saw that email. But I changed, it said it was only accepting PDFs. So I changed it to no restrictions. So
Okay, so you want me to go upload it?
if you can, that would be great. I know some
Okay.
people emailed me individually with their completion stuff, which is fine. So, okay, I do want to get into class because we've already wasted a half an hour, which it wasn't really a waste, but let me just think about how to go forward in this situation. If you have any ideas that you would like to share with me, send me an email. And just going forward for your practice test B, I would really just love to see that growth throughout the exam, that you're going in and you're looking up things and you're taking those notes. And going forward for me, I'm going to take a closer look at what you're actually, what you're actually submitting and what you're actually writing, so that I can appreciate the work that you're doing as well. Okay? I feel okay? Okay. All right, so we only have one chapter left for cardiac to go over. And how did you guys do studying since last Tuesday, since the last time I saw you? How do we feel about the key points that were sent? Did you see them? I hope you saw them.
I feel like I know a bunch of stuff, but I don't know if I know the right bunch of stuff.
Well, that's how we
I
always
have
feel,
such
right?
like test anxiety now since this is a repeat because this is like your last chance. So it's just like, do I know enough?
I understand
Because
that. I
everyone
really
says
do.
you can't know it all, but then you have to know it all for the test. So it's just it's a mind game.
Well, exactly why I try to give you some type of direction on what
Appreciate
I
that.
want you to focus on, but that doesn't mean that that's the only thing you focus on, right? I believe I just finalized the exam. I believe there's 38 questions. And I think I gave you 14 or 15 topics. So that's obviously not all of it, right? So there always is going to be, I can't give you it all, because then I'd get in trouble. But but at least you have just a little bit of direction.
What made it easy, this is kind of just like what I did was I went back and just watched through your lecture and wrote down basically everything that you said was important to know. And then anything that I written down that you had us write down in like our notes and everything, I went to the book and then went in order of how you did like your slides and wrote any extra like things that you didn't have on your slides but said was important. Kind
Yeah.
of.
Which is
Because you said
exactly
everything
why
is out the
I said-
book.
Huh?
I said, because you said everything was out the book, right? And I think that's what helped me answer my prep use really good too about the
Good.
drugs.
Because yeah, I always want you to be able to find the information that I'm teaching you easily, because I'm teaching you the standard. I shouldn't be teaching you my own stuff, right? I'm teaching you the standard that you need for your nursing practice for the rest of your career, not what Jessica Simmons thinks is right or wrong, right? Because that's how you're going to be successful throughout schooling and throughout your NCLEX and throughout your career. So that's exactly why I send out all of my lectures so that you have the opportunity to listen back and take those notes that you maybe couldn't get to in class. Somebody was going
I
to say
have
something.
a question. Yeah, about two of the things on the keynotes. One of them is how to bridge to Entresto.
Huh?
I don't know. Your keynotes, it says how to bridge to Entresto.
Yes, ma'am.
I don't know.
Did you look for it in your book?
I did, and I was looking at my notes, and I don't know, maybe I overlooked it.
So I actually added that to your keynotes because we did not talk about it in class. And I wanted to
Okay, so
make
I'm not.
sure.
Okay.
No, I wanted to make sure that the information was available to you. Because like I said, I am never going to test you on something that I didn't say from my mouth or that I didn't tell you to go look into. So, does anybody have the answer to that question? Anybody?
Miss Simmons.
Yeah.
For if you're gonna do like any sort of review at the end of class or anything, something that I struggle with is knowing like when to call the provider, like those priorities. I get those mixed up. And like I've tried to like write out, because I know ATI has like little tips on like the structures of those priorities. I know like ABC and stuff, but it's like, who do you go to? That's something that I guess
Like to look at?
review. Yeah. Thank you.
Yeah, we can do that.
The only
For the
thing I
bridge
know
to
about it is
Entresto, is that the waiting 36 hours after you stop the ACE?
you're
That's
you're
the
supposed to
answer.
hold it. You're supposed to hold it.
That
And
is the
then
answer, my friend. Can you
are
please
you
repeat yourself?
You wait 36 hours after stopping the ACEs, and then you can start the Entresto.
And that is the answer. Where is the stupid ring central thing?
if you have a question like that on our exam, would it be just after you hold it, you restart it, or would it be like you would restart it on a low dose?
Oh, I can't tell you that, silly goose.
I know, but
If you
figured
were
that.
to have an answer, a question like that on your exam that I'm taking tomorrow, give me the rest of the answer. Is this exactly what it's going to be? I cannot tell you that information, my friend. But I appreciate you trying.
Oh, I wasn't sure if it would just be like, start it again, or the correct answer would be started at a low dose. That's all.
I am going to tell you that I would love for you to look up that information, look a little deeper into it, and see exactly how you bridge from an ACE inhibitor or ARB to Entresto, and see if there are any other specific information about such things.
Okay.
Okay? Okay, so everybody good? How do we all feel about moving forward?
I'm so sorry to
Yes?
interrupt, but the classmate Alexandra just said, could you please let her in on her phone? Her laptop died.
Oh, I thought I did. I don't have anybody in my reading room.
I'm in.
Oh, okay. Okay, let's get through this last chapter. Okay, so this is chapter 49. So we have different components of the blood. First is your plasma, which is the liquid part of your blood, which is mostly water. It does contain proteins essential for immune response and blood clotting. And then there's formed elements of the blood. So you have the liquid part, and then you have things that float around within the liquid. Okay, so your formed elements would be your leukocytes, which are your white blood cells. And there, if you remember, there's lots of different types of white blood cells too. And obviously they are an important part of our immune system. Then we have our erythrocytes, which is your red blood cells. These carry oxygen to the tissues and remove carbon dioxide. What part of the red blood cell carries the oxygen?
Hemoglobin.
Hemoglobin. It just makes me think, did you guys see that TikTok where the girl was like, he hemoglobined all over the floor? It was really funny. If you didn't see it, you should look it up because it's really funny. Anyways, what is something that you need for hemoglobin to be able to carry oxygen to the tissues? Iron, yes. So iron has to bind with your hemoglobin for it to have good oxygen carrying capability. That's very good. And then the platelets obviously play an important role in coagulation. Erythropoiesis. Where does erythropoiesis begin? Does anybody know?
Is it the bone marrow?
No.
Myeloid tissue of the bone marrow.
No. Who is responsible for creating and what's the word? Excreting erythropoietin.
Is it the kidneys?
Yes, it's the kidneys. So, within our negative feedback system, our kidneys say, hey, there are not enough red blood cells around here. And it triggers the myeloid tissue of the bone marrow The erythropoietin goes into the bone marrow, and then that triggers the bone marrow to create more red blood cells, which start out as hemocytoblasts. And then they grow into reticulocytes, which then grow into mature erythrocytes, and then go into your circulation. So when you have a bunch of immature, those hemocytoblasts, a bunch of immature red blood cells floating around, but there's not a lot of mature ones, you are going to have decreased oxygen carrying capability because those red blood cells aren't really mature enough to carry all of the things that they need to carry, right? Because during this hemocytoblast and reticulocytes, between those two phases, we need all of these things. Just put you down here. For the creation of red blood cells, we need amino acids, lipids, and carbs. We need vitamin B12, right? We need folic acid. We need iron. If we don't have B12, we have macrocytic anemia. If we don't have folic acid, we have megaloblastic anemia. If we don't have enough iron, we have iron deficiency anemia. Okay? So it's within these two stages of red blood cell production that we don't have the nutrition or the vitamins to be able to get to the next steps of maturity of red blood cell production. Okay. So once you have your wonderful mature erythrocytes, they go into your circulation, and then sorry, that was a message from daycare. And then they are housed within the liver, spleen, bone marrow. And then during this 120-day life cycle of a red blood cell, because that's how long that they live for, when they get broken down, the byproduct is bilirubin, which turns into bile. Okay. So when you have a baby that gets severely jaundiced, my kid at 5 days old was hospitalized for severe hyperbilirubinemia. His total Billy was like 24. He was like this close to being admitted to the NICU. And I cried like a big baby. And even though he was only there for 24 hours. But it's the breakdown of the red blood cells and the bilirubin that causes jaundice in babies. Okay. And it's because they're broken down in the liver. The liver turns into that, it turns those blood cells into bilirubin, which is then bile, which then, if it can't get out of the body, it comes out into the skin and it turns the skin yellow. Okay. Factors essential to producing healthy red blood cells. We need an adequate amount of iron. It's used in the formation of hemoglobin rings to carry the oxygen. We need minute amounts of vitamin B12 and folic acid, forming a supporting structure that can survive being battered through blood vessels for 120 days. Essential amino acids, which are proteins and carbohydrates, complete the hemoglobin ring, cell membrane, and basic structure. So it's important to know that all of the cells in our body need amino acids. Amino acids are proteins, right? There are essential amino acids. There are non-essential amino acids. Your body cannot work properly without those essential proteins because they literally build our cell walls. Okay. That's why it's so important for if you're vegetarian and you don't get any protein from meat, you have to supplement in some way of getting those essential amino acids, or you will be malnourished and you won't have enough proteins for your body to work effectively. So types of anemia, we have iron deficiency anemia, which is a negative iron balance. We have megaloblastic, which is a folic acid or vitamin B12 deficiency. Pernicious anemia falls under this category. Then we have hemolytic anemia. This is sickle cell disease. This is an inherited disorder that causes abnormal hemoglobin. So instead of the red blood cells being donut shaped, they are sickled. So they kind of are like a half moon shape. I don't know if you guys know a lot about sickle cell disease, but it is very important to know that a patient in sickle cell crisis, which means they have more sickled red blood cells than they do normal red blood cells, is extremely painful. Okay? These patients are not exaggerating when they are coming into the hospital and complaining of pain in their legs, in their arms, literally all over their bodies. Okay? These patients, when they hit that sickle cell crisis, they are in an extreme amount of pain. And the only thing that can get them through that, because at this point, they're most likely extremely dehydrated, their hemoglobin is very low, most likely in like the 4 to 6 range, which is really, really low. Okay? And they need blood products in order to get better and to have less pain. They need rehydrated, and they need blood products. Does anybody know anyone with sickle cell?
My brother had sickle cell. He was shot in 2020, and so he would have survived, but he didn't because he had sickle cell, so his body just couldn't.
I'm
Yeah, I
sorry
just
for
got
your loss.
away from it.
My
Yeah.
kid's dad.
It's. Go ahead, Edna.
I'm sorry. My kid's dad had sickle cell disease. He was also shot and killed. But our kids have the trait. All 3 of our kids have the trait.
So they are carriers. They're carriers.
Yes.
So sickle cell is a recessive gene. So if you think back to our science classes, are the Punnett square, right? Where you have dominant and recessive traits. So if Edna does not have the sickle cell trait, her kid's dad does have the sickle cell trait, then that means if you were to do a Punnett square, that 3 of her children would be carriers. Well, no, all 4. No, 1 would not be a carrier and the other 3 would be carriers. But to both the mom and the dad both have to have the recessive gene to have a child that has sickle cell. Right? Yeah. Does that make sense? Because I feel like I said that really dumb.
I think. Well, he had the full disease. I had nothing. So all 3 of our kids carry the trait. But if they get with somebody with the trait, 1 out of 3 of their kids might have the whole disease. Yeah.
Exactly. That's what I was trying to say, but you said it better. I'm looking for thalassemia. Thalassemia, where are you? 881. Well, then I am way ahead then.
It's Jessica. I have a question about being a carrier. This may sound dumb. I don't know. I'm just trying to figure it out. So being a carrier doesn't necessarily mean that you will ever have it. It just means that you could pass it on to your children.
Correct. But there are people that carry the sickle cell trait that say that they have very small symptoms, that they can be a little bit symptomatic as a carrier, but they don't have the full-fledged disease. And their cells aren't exactly sickled unless they have both of those recessive genes. So just like Edna was saying, if one of her children, because all 3 of her children are carriers, if one of her children were to have a child with someone else that carries that gene, they have a 25% chance of having a child that has sickle cell. So it's very important that if you know that you're a carrier of sickle cell, that you discuss possible genetic testing between you and your partner to make sure that the partner that you are having children with is not also a carrier.
Yeah, my dad didn't know that he had the gene, and obviously until my brother was born,
Yeah.
and then they figured it out. So he has 17 kids, and I think 7 of them have the trait, and 1 of them had sickle cell. So yeah.
Wow. Wow, wow,
Yeah.
wow. That's an impressive number of children.
Yeah, it is.
In the
Okay.
US now, when you're
We talking
born,
about
you
your
get
dad,
tested for
Marissa?
sickle cell.
You know I am.
I love
Brandy.
Marissa's dad.
Brandy, what were you gonna say?
When you're born now, they automatically test all infants on the newborn screening for the sickle cell trait.
Yeah, it's good. I mean, it's a good thing that they do that because they want to manage it appropriately right off rip. All right, so thalassemia 881 is a group of inherited disorders that can cause decreased synthesis of alpha or beta globin chains in hemoglobin. The severity varies depending on whether the person is heterozygous or homozygous for the genetic trait. These disorders generally lead to hypochromic microcytic hemolytic anemia, in which ineffective maturation of the red blood cells leads to early lysis. So that sounds very sciencey, but what that actually means is there is something wrong with the way that the red blood cell is being produced. So they have a hard time maturing, and in that hard time maturing, they have less survival days. They don't meet that 120 days of survival. Okay, so you become anemic because the production of red blood cells is happening, the maturation is not happening. So you don't have enough blood cells maturing to carry around the oxygen needed for the body. Okay, so when you have anemia, what type of symptoms do you think you would have if you are very anemic?
You would be cold,
Fatigue, cold,
Dizziness.
dizzy. Why?
Tired.
Why dizzy?
Because you're not getting enough oxygen to your brain.
Yes, because there is a lack of oxygenation, because there is a lack of oxygen carrying capability. I love that you're making that connection, because that is a connection that you need to think about for literally the remainder of your career. Everything that causes hypoxemia is going to cause a set type of symptoms, right? Fatigue, dizziness, increased risk for falls, possible confusion, right? Pale, cold. There are all of these things that are symptoms of hypoxemia that occur when oxygen isn't getting to the right place. Okay? All right, so iron deficiency anemia, relatively common people in certain groups. So people that are menstruating, who lose a lot of red blood cells during menstruation. And then you're also not replacing those red blood cells as fast as you need them, right? Pregnant and lactating people who have decreased demands for iron. If you do not know, your blood volume like practically doubles when you're pregnant, at least by half. Your blood volume increases at least by half while you're pregnant, which is really hard for your body to achieve. And if you have decreased demands for iron, and your body isn't saying, hey, I need this, or you're not taking the right prenatal vitamins, then you're not getting enough iron to support the amount of increased blood volume that you have. Rapidly growing adolescents, especially those who do not have a nutritious diet. So if your kid all of a sudden grew 5 inches in the last year and all they eat is chicken nuggets and chocolate, then they're probably a little deficient and may find themselves anemic because they're not getting the vitamins and minerals that they need to support their rapid growth. Okay. And then obviously people with GI bleeding. This is really any human with excessive bleeding. Okay. It doesn't have to be menstruation. It doesn't have to be GI. It's the fact that you're bleeding more than what you're producing. Okay.
I'm anemic and I have to go get blood transfusions.
Yeah. What type
Yeah,
of
and then-
anemia do you have?
I just know it's an iron deficiency.
Okay.
And then when because like I'm pregnant right now, so it makes it 10 times worse. And that's when they like amp it up. So I have to go get tested all the time for it.
Are you taking vitamin D?
Yes, ma'am, I am.
Good. Why do you need vitamin D for your iron?
Don't play with me right
Helps
now in
absorb.
front of all these people.
She said, "Don't play with me right now." You need vitamin D for your body to actually use iron proficiently. So I'm not going to go into like the whole science of it because actually I don't know the whole science of it, but I do know that you need vitamin D for iron to be used effectively especially for people that are anemic. There's a lot of people that actually will
Can you
drink
mute
like
me?
a
It
whole-
won't let me click it.
Yeah, there's like a whole group of people that swear by orange juice. And they drink orange juice like every day, like a big glass, because it has vitamin D in it. Okay, anyways, so we have folate deficiency, which is certain malabsorption states, like celiac disease. I don't know what sprue is. It's interesting. Malnutrition that accompanies alcoholism. This is a big one. This is a big, big one. So you'll notice throughout your career that when you have a patient that is admitted with ETOH, which is alcohol, ETOH, history or current ETOH abuse, they will most likely be on vitamin B supplementation, B6, B12, because alcoholism does something to the way that you absorb the vitamin B, all of your vitamin Bs, because there's so many of them, but specifically vitamin B6 and B12. Okay. Repeated pregnancies, if you have, if you are malnourished and you don't have good prenatal care, or that you're already deficient when you get pregnant, and then you have a baby, and then you get pregnant like 3 months later, and you never fix the malnutrition that you already had from the previous pregnancy, you're going to have it again. And probably worse. Extended treatment with certain anti-epileptic drugs. Vitamin B12 deficiency, people that have a strict vegetarian diet are at risk for this, and inability of GI tract to absorb the vitamin. If this is your issue, the inability to absorb, this is probably somebody that's going to be on vitamin B, like intramuscular shots weekly for probably the rest of their life. Oops. Megaloblastic anemia usually occurs when there's an insufficient folic acid or vitamin B12 to support the stromal structures of the red blood cell. I already showed you that. It is true. Megaloblastic anemia usually results from insufficient amounts of folic acid or vitamin B12 to adequately create the stromal structure needed in a healthy red blood cell. So this is just talking about sites of action of drugs used to treat anemias. So if your issue is that your kidneys are not producing enough erythropoietin, we have drugs for that. Okay. One of them, Epotin Alpha, I believe the brand name is Epigen. And then you also have this Darbepoetin Alpha. So anything that has, my brain is trying to say it right. Epotin, something that makes you think of erythropoiesis. I want you to automatically start thinking of red blood cell production, and it has to do with the kidneys. Okay. When you're taking hydroxycobalamin, that is vitamin B12. That is a big fancy word for vitamin B12. Okay, the C, cyanoco blah blah blah. That's a really hard word to say. Okay. And then you have your folic acid, and then you have 2 other drugs that help with folic acid, and then of course iron. Okay. Erythropoiesis controls the rate of blood cell production. We already discussed this. So it all starts with oxygen use. So your body, so this is your negative feedback loop right here. Okay, this is a perfect example of negative feedback. So the oxygen use in your tissues is high. Okay, every part, every organ, every single cell in your body needs oxygen. You have decreased oxygen in your blood, and your arteries sense that. And they're like, hey guys, this is not enough. I need more. So then the blood goes to the kidneys, and the kidneys say, okay, I'm going to give you some erythropoietin. So the erythropoietin goes up. This increases stem cell stimulation within the bone marrow. Red blood cells are formed. They have to mature. And then we have increased oxygen carrying capacity, which increases your oxygen that's going around in your arteries, which then decreases the stimulation of erythropoietin because the demand was met. Okay. So you always remember, this is hemostasis right here. Okay. This is how your body balances everything it does through this negative feedback system, just in different ways. Erythropoiesis stimulating agents. So we already talked about this. Epotin alpha, which is also known as Epigen. And then you have 2 other ones. May benefit patients who are no longer able to produce enough erythropoietin in the kidneys. And you must ensure that the patient has adequate levels of components required to make red blood cells, including adequate iron. So what I want you to know and take from this very specific moment is I want you to know what we need, what I need, what you need to make a healthy red blood cell. Do you need it for tomorrow, or do you need it for your final? I don't know. Who knows? But I'm pretty sure I would want you to know that. You have a box warning on erythropoiesis stimulating agents, which increase the risk of death, myocardial infarction, stroke, venous thromboembolism, thrombosis of vascular access, and tumor progression or recurrence. Why would this put you more at risk for stroke or embolus?
It would increase the clotting, right?
Why?
Because it's more platelets.
So the erythropoiesis is stimulating your bone marrow, right, to produce red blood cells. And all of a sudden, your blood just got a lot more viscous. What does viscous mean? Thick. Your blood is a lot thicker than it was a little bit ago. Okay? The thicker the blood, which when you don't have enough hydration to support all of the solutes in your blood, is when things get very viscous, very thick, and when you're at a higher risk for stroke, MI, PE, DVT. Okay? So this acts like the natural glycoprotein erythropoietin to stimulate the production of red blood cells. It's indicated to treat anemia associated with chronic renal failure or kidney disease. You're not giving this to a person that's iron deficient. The problem isn't that they can't make red blood cells if they're iron deficient. It's the fact that they can't have enough iron in the maturation process to carry enough oxygen, right? So when you're thinking about anemia and the treatment of anemia, you have to remember the cause. So if your cause is chronic renal failure or kidney disease, then the problem is occurring right at the beginning. That the hormone secretion isn't there. Okay? If it's folic acid, it has nothing to do with erythropoietin. It has to do with the fact that you don't have enough folic acid for the maturation of red blood cells. Okay? So, erythropoietin is metabolized and excreted similarly to the endogenous erythropoietin. That means that it's removed from your body the same way that the actual hormone is removed from the body. So you don't see a lot of toxicity in this type of situation because it mimics the natural hormone. Okay. This is contraindicated in uncontrolled hypertension, known hypersensitivity, and no adequate studies in pregnancy or lactation. So they probably aren't going to give this to any pregnant women. Uncontrolled hypertension, why? What did we just talk about?
It's gonna make your blood thicker.
Right?
And
So if we
chance-
have an increased risk for stroke, MI, PE, DVT, clot formation, if you have uncontrolled hypertension, that risk is going to go skyrocketing. Okay? Caution with some cancers, normal renal functioning and adequate levels of erythropoietin. I'm not giving this to someone who doesn't need it, right? So adverse effects, this can affect your central nervous system, nausea, vomiting, diarrhea, cardiovascular symptoms, serious effects and increased risk for DVT when hemoglobin is higher than 11. That looks like a zebra to me. So drug-to-drug interaction, this drug is never mixed with other drugs, okay? This is given by itself, by injection. You're not mixing it. You're not putting it in an IV with other drugs or whatever. It's given by itself, always, all the time. So this is just looking a little bit closer at Epogen, which is the brand name for this drug. This is for the treatment of anemia associated with chronic renal failure related to the treatment, could be related to the treatment of HIV infection or chemotherapy in cancer patients, to reduce the need for allogenic blood transfusions in surgical patients. That means that, and this isn't done often, but that means that this person can be treated with erythropoietin pre-surgery, like a couple weeks before surgery, help them increase their red blood cell production to try to compensate for the blood loss that they could have during surgery. And like I said, doesn't happen often. Adverse effects include headache, arthralgias, which is joint pain, fatigue, asthenia, dizziness, hypertension, edema, chest pain, nausea, vomiting, diarrhea, DVT, and thrombotic events. Agents used for iron deficiency anemia, they're going to be all of your ferrous drugs. Ferrous means iron, right? So you have ferrous fumarate, sulfate, gluconate, sucrose. You have all kinds of different types of iron drugs. But if you ever see the word ferrous, or obviously iron, that has to do with iron supplementation. So this is, of course, the whole point of this is to elevate the serum iron concentration. It's for the treatment of iron deficiency anemia. It may also be used in an adjunctive therapy in patients receiving an erythropoiesis stimulating drug because they just want to, if you're having a mass production of red blood cells because you're getting infused with erythropoietin, you want to make sure that that patient has enough iron stores to adequately support the mass of red blood cells they're about to produce. Does that make sense? Okay. So primarily absorbed from the small intestines by active transport, transported in the blood, it is bound to the transferon. Small amounts are lost daily in the sweat, urine, sloughing of skin and mucosal cells, and then sloughing of intestinal cells and menstrual flow. Contraindicated and allergy, of course. Hemochromatosis, anemias that are not iron deficiency anemias, normal iron balance, peptic ulcer disease, colitis, or regional enteritis. What is a something you would want to teach your patient about taking iron supplements?
Those black target stools can become constipated.
Yes. So your patient is at very high risk of constipation when they're taking iron supplements. And they also have the possibility of changing the color of your stool to black and yucky. So it's important that they know that, first of all, if you have black tarry stools, you still need to notify a provider. Because what could that also mean? A GI bleed.
A GI bleed.
A GI bleed. Most likely an upper GI bleed, because the longer blood stays within your intestinal tract, the darker it gets. Okay? The lower it is in the GI tract, the more red it is. Okay, so if you have bright red blood coming from your rectum, it's most likely coming from a hemorrhoid or right inside the rectum or sigmoid colon. If you have black tarry stools, it's coming from an upper GI bleed. Okay. What is also something you would want to discuss with your patient if they need to drink their iron?
I think if you drink it with
Never
orange
mix
juice.
No. What did someone else say?
Like if you drink it with orange juice, doesn't that help absorption?
Yeah,
Or
but
no?
I'm talking about if you have to drink an iron
You're
supplement.
never supposed to mix it with potions.
Correct. But it's something very simple.
Is it
Yes.
milk?
Yes. You need to drink it with a straw because you don't want to just take a big gulp. It can stain your teeth. So if you have a patient, especially children, that have to drink iron supplements, they need to drink it through a straw or it will stain their teeth. Staining of the tissues. What does that mean? On page 887, figure 49.4, it talks about a very specific method of injection. Did you find it? The Z-Track method. So the purpose of the Z-Track method is a technique for injecting. It moves the skin to one side. You insert the needle at a 90-degree angle, aspirate for blood to make sure you're not inside a vessel. You want to inject and then withdraw the needle, and then move your hand so the tissue goes back. So what this does is that it prevents the displacement of iron. So when you withdraw and you move the skin back, that iron doesn't come to the surface and stain the skin. So the Z-Track method is still used. Had someone say to me in my leadership clinical on Friday or something that somebody told them that the Z-Track method is not used anymore. It absolutely is used because IM injections are still going to cause staining of the tissues. And that's the whole point, is to minimize staining of the tissue. On page 888, it talks about CNS toxicity with increasing serum levels. Let me find it. Bless you.
Bless you.
All right. I literally have it marked, but I can't find where it is, where it says it. Oh, CNS toxicity progressing to coma or death with overuse. You have interactions with, first of all, you never want to take any drugs with antacids, but especially iron, you don't want to take with antacids. Or any substances with increased calcium or magnesium, which is an antacid. Tetracyclines, which are antibiotics. Chimetidine, which is a, oh my God, my brain.
Allergy pill.
Thank you. Yes. Fluoroquinolones or tetracyclines, which are also antibiotics. Levodopa, which is an anti-Parkinson medication. Drug food interactions. You do not want to take iron with eggs, milk, or other calcium containing substances, coffee, tea, or vitamin C. Okay, so this talks about chelating agents. Chelating agents are given for toxicity. Okay, so heavy metals, including iron, lead, arsenic, mercury, copper, and gold, can cause toxicity in the body with their ability to tie up in living tissue chemicals that need to be free in order for the cell to function normally. So, chelating agents grasp and hold a toxic metal so that it can be carried out of the body before it has time to harm the tissues. So, this is what is given to people that have heavy metal toxicity. Okay, who is at the highest risk for this? Little people, little humans, little children. Okay, not only do they get their hands on things they shouldn't get their hands on and take a bunch of them, they put everything in their mouth, but also kids that are on iron supplementation, if they're not watched closely, if they're taking little gummy vitamins that have a bunch of iron in them and they get a hold of the bottle and they eat the whole bottle because they're full of gummy vitamins and they taste good, but they also have added iron supplementation. That's called poison control, right? So There are lots of drugs that can be given for different types of toxic metals. This box 49.5 is on page 888. Okay. So our question, we have a 4-year-old child who was brought to the emergency room in shock. Their patient states they found the child eating iron fortified vitamin pills about 2.5 hours ago. The parent estimates the child ate close to 200 tablets. What medication would you expect the physician to order for the treatment of iron toxicity? So if we had absolutely no idea what the answer to this question is, it definitely wouldn't be this one, because this one is too close to ferrous gluconate, which is an iron supplement, right? Penicillamine, that's an antibiotic. That just makes me think of antibiotics. That can't be it. Levoglutco, I don't even know what that is at all. This one at least has D-ferro. That makes me think, so something ferro, that's something with iron, right? The D makes me feel like it's doing something about it. It's taking away, right? So if I was looking at this and had absolutely no clue what the answer could be, process of elimination is going to bring me to this guy. Okay? So the answer is A, this is given in IM injection or IV form to treat acute iron intoxication. Agents for megaloblastic anemias, we have folic acid and vitamin B12. I feel like that's pretty self-explanatory. Is vitamin B water or fat soluble? Water. Vitamin B's are water soluble. Can you take a vitamin B complex every day?
Yes.
Why? Because it's water soluble. What does that mean? If there's too much of it,
You just pee it out.
excrete through the urine. You ever take a vitamin, then all of a sudden your pee is like highlighter yellow? That's your body excreting all of the stuff it doesn't need. Okay? Because they've already met their vitamin requirements of water soluble vitamins. They don't need the rest of them. So your body's like, okay, bye. I don't need you. Okay? So we can have toxicity of fat soluble vitamins because they're really not easy to excrete because we need fats to make them soluble. But with water soluble vitamins, they're easily excreted when there's too much or that we've already met the demands our body needs. Okay? So they are essential for cell growth and division for the production of strong stroma in red blood cells. Folic acid is necessary for production of DNA, red blood cells, white blood cells, and platelets. Vitamin B12 is necessary for the maintenance of the myelin sheath in the nervous system, in the nerve tissues. Indications for replacement therapy for dietary deficiencies in high demand states like pregnancy and lactation. Treatment of megaloblastic anemia. Folic acid is also used as a rescue drug for cells exposed to some toxic chemotherapeutic agents. These are well absorbed after injection, metabolized mainly in the liver and excreted in the urine. B12 can be given through, what is that called when you squirt it up your nose? When you give it through like a nasal spray, okay? This can cause the breakdown of your nasal tissue and cause ulceration. There are really only a few adverse effects. If you have a high amount of, I think this is B12. Itching, rash, signs of excessive vitamin B levels. So if you have a lot of them and your kidneys can't excrete it fast enough, you might have some of those adverse effects. Mild diarrhea, pain and discomfort at the injection site, and then nasal irritation. That's what I was looking for. Intranasal spray. That's what my brain couldn't figure out. So when you are considering megaplastic anemias, you want to make sure you're looking at your patient's history and physical, if they're pregnant or lactating, if they already have erosion within the nasal tissue, their affect, orientation, reflexes, pulse, blood pressure, perfusion, respirations, all the things. Folic acid and B12 should be used only with caution in pregnant and lactating patients. True or false?
False.
That is false. These vitamins are considered essential during pregnancy and lactation because of the increased demands of the pregnant person's metabolism. Folate deficiency during pregnancy can cause neural tube defects. We're almost done, and then we're going to take a break. Agents for hemolytic and aplastic anemia. Some patients with sickle cell anemias are treated with antibiotics. Prescription medications for sickle cell include these drugs. The only one I can really pronounce is hydroxyurea. If you have aplastic anemia, this is immunosuppressant drugs, corticosteroids, or replacement elements in critical situations, and this is the drug for treatment of aplastic anemia. I don't really need you. Hydroxyurea increases the amount of fetal hemoglobin produced in bone marrow. This luspatercept, it's administered every few weeks to patients who require red blood cell transfusions due to anemia associated with beta thalassemia and some myelodysplastic syndromes. When you see this myelo, what does that mean? M-Y-E-L-O, myelo. Nope.
Bone marrow.
Muscle.
Bone marrow. Myelo for muscle is like M-Y-L-O. My yellow is bone marrow.
Does that have anything to do with that prefix with like the myelin sheath or whatever
Myelin
with
sheath?
neurotransmitter? Yeah.
So the myelin sheath so that's a great question. That's a great question. I need to look into that. Because the myelin sheath is not bone marrow, right? So if you were to see the word myelosuppression, that would mean bone marrow suppression. That's what that word means. And you're going to see that in the next, throughout the rest of schooling and sometimes within your career. But a myelin sheath is the protective sheath that goes along your nerve transportation. So I would have to look at that. Anyways, these drugs are contraindicated and used with caution with obviously a known allergy, pregnancy, and lactation. Hydroxyurea is you want to be careful with a severe anemia, leukopenia, or impaired renal or liver function. And then this one you don't want to give with chronic hepatitis C or patients of Eastern Asian heritage, which I do not know why. Okay. So for hydroxyurea, the GI effects, or it has GI effects, dermatological effects, bone marrow suppression, headache, dizziness, disorientation, fever, chills, and malaise. Malaise is just like a really generalized, I feel like crap. Okay. Lethargy is like, I'm just like tired. Malaise is like an overall poor state of being. Okay. Oh, about anemias, drugs that treat anemias. Did you guys see all of the added things that I put on Brightspace? All the little picture guys. Are they blurry? Did anybody look?
Some are blurry and very limited.
Yes. So those
Yes.
came from a book that one of the other instructors have that I like took copies of. But I didn't want to not upload them. I need to find better pictures that are more clear, because I remember a couple months ago some people had issues seeing them, and then some people was like, no, it's fine. But I didn't want to not give them to you. So, but I'm hoping that they were helpful. I'm also hoping that the right and left-sided heart failure stuff was helpful. Let's take a break. Oh, it's already 11. What time are we here till? 1:30? 2:30? 2:30. Are you guys hungry? Do you want to do lunch now and come back? Because it's already 11:07. And then when we come back, we'll review. All right. Let's take a half hour for lunch. Okay. We'll come back at 11:40.
Miss Simmons.
Yeah. Who is that?
It's Carly. Can I ask you a few questions, like in a different, like in a private thing in a couple of minutes?
I wonder if I'll put you in like a break. We'll be separate.
That's usually the right.
Breakout. Okay. I did it.
Okay, can I ask a question about the ATI just because you guys talked in circles for so long?
Yeah, hold on one second. Somebody just asked me in here if there's any bow tie questions on the exam. There is one bow tie question. I am infamous for bow tie questions because I like, the whole point of progressing through nursing school is being able to connect all the pieces together through your nursing process. And that is one thing that bow ties, you have to look at the problem, you have to look at what happens before, what you need to implement, and then how you need to evaluate those implementations. So yes, I love bow ties. Okay, go ahead.
Okay, so for ATI, are we supposed to remediate on our first attempt like we have been doing?
Yes.
So that's what we decided through the whole conversation.
Yes. Remediation on your first attempt.
That's how I thought it was supposed to be done, but
Yeah, absolutely. I don't want to see a remediation on a 94%. But if you're going to turn in a ATI practice that has a significantly crazy high score, I want to see the progression and notes that were made throughout that process, because that's just not fair.
I usually just take it once, remediate, and then if I want to take it again, I take it when I'm done.
Yeah.
So-
Well, and then also you have to think about that
again.
you're not repeating the course. And some people are repeating the course, so it is the second time that they took the exam, which is something as an as the instructor for this class, I have to think about. because it's almost, I mean, they've taken it, more than once. And by the way, you can take it as many times as you want. It's an unlimited amount of times you can take the practice test.
And now it pops up. It didn't do this last time. We did them with flashcards. And then there's also a post-study quiz.
Did you guys see the email that I sent you about the flashcards?
Yeah.
And I found that with my leadership students because I had to cover a clinical Thursday and Friday. And that was amazing. You can get 300 flashcards that are literally tailored to your proctored exam. And a lot of people did not know that.
Yeah, the last time we did these API on this, it didn't show us, it didn't have a flashcard when we did it. But
It's a new update.
Yeah, it's a new update within ATI. Just like everything is evolving. All of our technology is evolving, which is what I just got to talking about.
Miss Simmons,
Okie dokie. Yeah.
do you know how many questions are on our test?
I sure do. I made it. There's like 37 or 38.
Oh, that's not bad at all. Okay, thank you.
Justice said, could you let her in?
Oh, yeah.
So from this point forward, this is test 2, correct?
We're talking, what do you mean? Like ATI test B?
No, what you're going to start teaching.
No, we're going to go,
Exam 2, yeah.
no, we're going to review a little bit and then we're going to start onto our next content.
Okay, I was just doing it for organization purposes. That's why I was asking.
Oh, yeah, you're fine.
Miss Simmons, where did you say we can locate the flashcards on ATI?
So you go in, I don't know, I sent like a step-by-step in an email. I don't remember.
If you go
Okay,
into
well,
your
I'll get the email.
ATI, your exam, it says it right there where you have to download the report. It says it right in there. It says flashcards.
Okay, thank you.
Well, there's also another way where it's just pharmacology. We have this, we bought the entire ATI like program, which comes with this thing called Engage, which is where those flashcards came from. So when you go in and find the flashcards, it says Engage ATI pharmacology. And remember, make sure you pick the one for RN because there's also one for PN. And you are obviously in an RN program, so you want to make sure you're looking at the right ones. All right, so who already started working on their key points? Who's
I
done?
did.
Doing that now.
I did.
Already working. I have questions too, though.
Okay. Questions that I'm actually going to be able to answer? Or questions like, is this on the exam and what is it going to look like on the exam? That I cannot answer.
You may be able to answer it. So basically, hold on, let me go to my notes. So when I was looking through everything for the bridge from the heparin drip, it was basically saying different things. So number one, it was saying that for warfarin, while on heparin, I guess you wait a day to start the warfarin, and then you continue for at least 5 days. And where I'm confused at is I don't know if it's or if the INR is greater than 2 for at least 24 hours, or it has to be both.
Okay. When you bridge a patient from heparin to Coumadin or any other anticoagulant, What the most important thing that you're taking away from this is that heparin is immediate. Okay. IV heparin, sub-Q heparin, these drugs act immediately within the system. Okay. When you switch to a PO anticoagulant, they can take 3 to 4 days to become therapeutic. So you have to have a patient on a heparin drip at a therapeutic level for days, and right in the middle of that, you are going to be starting them on a PO anticoagulant like Eliquis or Coumadin or Pradaxa or whatever, because you can't leave them without anticoagulation while that PO medication is becoming therapeutic. You have to maintain their therapeutic level with the heparin while the PO medication is building in their system. Okay. So is it possible for your patient to be on heparin and Coumadin at the same time?
Yes.
Yes. Yes. Because it takes Coumadin 3-4 days to become therapeutic, and a therapeutic INR is between what and what? That's
2 and 3.
A therapeutic
What was-
INR is between 2 and 3. Okay.
You're saying while on heparin?
What?
You went out. I didn't hear.
Oh, did I get disconnected from my hotspot? No, I'm still
No,
on
I
my
think
hotspot.
you just went out for me. I'm not for sure. I didn't hear what you said.
Okay. I said a lot. Which part?
About the INR.
Oh, so your therapeutic INR is between 2 and 3. That is the therapeutic level of where you know that your warfarin or Coumadin is in a therapeutic place, is when your INR is between 2 and 3. All right. So those of you that have done your key points, do you have a question about a specific subject? Because those of you that haven't done it, I'm not going to sit here and just give you all the answers. I don't think that's fair to the people that put in all the work for the key points already.
I had a quick one. So when you're talking about atropine, you wanted to know everything from like the pharmacokinetics to pretty much what it does, how it works. And do you need to know the administration also?
The most important things for atropine for me and for really your nursing career is when it's given, why it's given, and how it's given. When, why, how.
Thank you.
You're welcome. You guys, anybody in here? Questions about key points?
When you were asking about cell physiology, are you talking about like the components within the cell, like the mitochondria, ATP?
Amen, sister. Yes. So cell physiology, what do you need for a cell to be healthy and do what it's supposed to do? Okay. Understanding cell physiology is really going to help you understand the pharmacokinetics of how drugs work within the cellular structure. Right? Remember, we were talking about the doors outside the cell along the cell membrane and how certain drugs are able to unlock those doors so that things can come in and out of the cell, the different types of diffusion, the way that things come in and out. Okay. Some are from active transport, some are from diffusion, osmosis. These are just things that I that is just important for you to understand in general, to be able to then understand the anatomy and physiology, to the pharmacokinetics, to the pathophysiology of the disease process. Okay? It's all about connecting those dots.
When you're saying right and left HF, are you talking about the medications that treat the different ones? Or are you talking like right breast, left lungs?
I want you to understand the presenting, the way that your patient is going to present with each disorder. Your patient came in with +3 pitting edema, JVD, and their lung sounds are clear. Which sided heart failure are we talking about?
Right.
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 Exactly. If your patient came in with a moist cough, pink frothy sputum, with no peripheral edema, what are we talking about?
That's left-sided heart failure.
Left.
I just wanted to make sure I knew what I was looking for.
Oh, you're good. You're good.
It's like easy to when we're talking through it, it's like easy to answer like what you're asking for. But when we go to take the test, it's like maybe it might just be one specific thing that's not there. I think that's the issue for me anyway.
I seen this TikTok and it said that pharmacology is not about like memorizing things, but it's about like the critical thinking. And I think that's why when you work with us and we like talk through it, it's easy for us to understand it. And then we see it and we're like, so then it's like that's my difficulty. At least it's like I can look at something and I'm like, yeah, I know that, and then I'm like, wait, why is it this for that? And then you know what I mean. So that's why like when I do like the dynamic quizzes, I do it so like when you click the right or wrong answer, it shows you the rationale for it, whereas you can turn that off and on. But like that's the way I try to break things down, and I still sometimes have like such a hard time putting certain things together.
Yeah. So you should always have your rationales on, because that is knowing right in the moment why a question is right or wrong is so important to build your knowledge in the moment. So you really should have your rationales always on. You really shouldn't turn it off. And I like to include them in my exams too, because when we go over the exam, I want you to be able to learn and build from it, because I want you to be able to recognize it and get it right in the future, the next time you're presented with that situation. So you're right and wrong when it comes to pharmacology. Pharmacology is different from the different topics of nursing because it's half critical thinking and application and half black and white. So a lot of nursing is not black and white, right? Like there's so many gray areas. There's so many, oh, well, what if this happened? And then this happened, and then that happened, and then this happened, right? There's so many ways of like, well, what if you thought about it this way? And what if you thought about it that way, right? But when it comes to pharmacology, a lot of the times there is a clear right answer, a clear wrong answer. But then when you get into critically applying things in pharmacology, what gets people is that number one, you have to recognize the disease process, right? And then number two, you have to recognize how you treat that disease process. Number three, then you have to pick the correct medication to treat that disease process. And if you get 1, 2, or 3 wrong in that sequence, you get the question wrong. If you aren't recognizing the pathophysiology and the anatomy and physiology of what's being presented to you, that you're missing right off rip. Where am I going with this? Because you're not understanding the first part of the equation. You look like you have questions. What's your question? You got no question? All right. Anybody? Because we're gonna go into our next stuff.
I have a quick question. Are we
Go ahead.
going to be able to see our grade after our test?
Yes, ma'am. I pride myself in getting my test evaluation and grades in before you even get back to my class.
I mean, like when we hit submit, when we're done, will we
Oh.
be able to see
I think so. Aren't you always?
Yeah.
it? No.
Our last teacher
We
said
were
it,
up
but no.
until personally for me,
Up
when we
until-
did the advanced farm in August, we had a complete change in ATI and we were not allowed to see our score until
It was
she
very
went
sketchy.
over. And she said it was
everybody a heart
mostly
attack.
because she said it was mostly because she didn't want people to get 65, but then her go back in and review her questions, and then she gave back 5 to 10 points, and we ended up with the 75. So it was more about like a panic attack. But I've also had other instructors say that who's to say you can't take away points? So then we were always like, well, how do we even know what we got to see where we ended?
Right. It was very, I
Yeah,
think we waited
absolutely
almost
not.
for 24 hours to see our score.
I had the
absolutely.
opposite even, and they wouldn't allow me to discuss it because she wouldn't even meet with us to show us our exams. So even after our final, we didn't know our final grade until almost 2 days after we took our final for the class. So I couldn't even appeal it at that point.
Yeah, Dr.
absolutely
Schwartz
not.
said that unless I drove out to her campus, I was not allowed to review my exams with her, which that's
Absolutely.
an hour and 45 minutes for me. So it was a little bit hard.
So we're all traumatized from 2 months ago.
I can see
A
that.
lot. It was bad. It was like bad.
I
I
really
can see
question
that.
my entire life choices. So
I will never, ever, ever in a million years do that to you. As soon as you hit submit, your answer will be available, or your test grade will be available to you. If there is a situation where your grades aren't inputted, like updated before we get back to class, then that means that I'm dealing with something personal that I have to deal with in that very moment, like my son or my husband, and something's wrong and I need to leave and go deal with that. Because usually I do my test analysis literally the moment that my last person is done. And then I update my grades in my grade book before class even starts. I went to nursing school and graduated 8 years ago, and I remember taking my tests on those little Scantron papers and then having to wait 3 days for our test results, and it was literally the worst moments of my life. Throughout school, just waiting and dreading. And I don't ever want you guys to not be able to focus and learn because you're so worried about what I got, what did I do, what did I this, what did I that. No, absolutely not. One thing I did talk about in the beginning last week was I haven't really decided yet, but because there's so many of you, and depending on how many people do want to go over their exams, we're either going to go over exams like as a group, because I don't have the time to meet with 43 people to go over exams individually. Unless like you have a very specific like SAP situation. So I'm probably going to go over exams as a group.
She didn't even let us do our SAPs.
Yeah. You guys should write some emails.
we did. It didn't matter.
Oh,
Wait,
what
yeah,
I
we
did.
definitely did.
A lot.
She said, what are SAPs? SAPs are student
We did
academic
a
progress.
lot.
If you get less than a 76% on an exam or fail a math test, you should automatically get a SAP, which is an email from me.
Okay, I
which
got one
is-
of those for math last month. Okay, I know what you're talking about now. I was like, wait, what is that even called?
Yeah, so it's actually required for all students that receive a SAP to, bless you, to meet with their instructor.
Like Mr.
So
I'm gonna send you my appeal because I did all of that and it still got denied. I did everything. I looked through the
well,
handbook. Yeah.
I will say, my mic? Oh, appeal. I can't do anything and nobody can do anything about things that have happened before. But all we can do is move forward. So believe me, I wish that I could go back in time. I wish that I came here sooner. But there's nothing I can do about that. So, any
Like,
more questions?
I have so many questions for you, but because I'm so traumatized from the last time we had this class, I don't want to ask any questions because I was made to feel so stupid on a lot of things. Like I am literally sick for tomorrow. Like I don't even want to show up tomorrow because I'm so
Okay,
traumatized.
Please show up. I really need you to show up because I really don't want you to take a 10% deduction over something that I know that you know.
Like I feel like
I
crap
need you
because
to believe me when I say that we're going to get through this together.
like I'm shaking. I really am.
I can hear it in your voice. And I'm
It's so
sorry that
frustrating.
I'm really sorry that that happened to you. And I'm also at the beginning when we first came out with the schedule for this month, I was supposed to be splitting this class with another instructor. And I kind of made a little bit of a stink about it because I didn't want to. And I'm really, really glad that I got to have this entire class because it was really hard knowing and not having any control over the other half of this group that I couldn't help or couldn't do anything for. And that was really hard for me. So, and
Just
that's
so
not
you
to
know,
say
you're
that
doing
I
a
didn't
lot for us, so we appreciate it.
And that-
I would
Yeah,
rather
I
fail your
agree.
class than the last one because you're actually teaching us, and I know you're giving it your all.
trying, girl. And that's not to say that I didn't have a couple people fail my class and because I did, and it was absolutely devastating for me. So it was really hard.
We had 6 out of
Are you
10
able
of our group fail.
I know, and there was a big group from Niles, right?
Mm-hmm. Only 4 passed, I'm pretty sure.
Yeah, it was a big group from Niles.
You have a
What's
very
are
good
you
reputation,
how many
just so you
passed?
know. We hear nothing but good things about you. Like going into this class, we had heard nothing but good things about you.
Thank you very much. Guys, just give me a big old head. My head's gonna explode if you keep going.
Well, if you
Are
deserve
you
it, then
able
you
to
deserve
share
it.
how many?
Thank
Is
you.
this class and
give
critical
credit
care
where
the only
credit is due.
classes you teach? Or which other classes do you teach?
I teach Complex Care 1 and Complex Care 2. And I don't split
Okay.
those classes.
Okay.
All right. So, any more questions? Because we only have 2 hours, because you guys are going to have another break at least, about the key points before we move forward with lecture.
Can I just send you
'Cause
an email with my questions?
Absolutely.
Okay.
If there are questions regarding the exam, would you be okay with sending it to the entire group for me to answer?
Yeah.
Okay. Okay.
Just
And
have one.
also, go ahead.
With the anginas, I know it is the stable, unstable variant, and then is it Prince-Metal? Is the variant the Prince-Metal?
They're the same thing. Variant and
Okay.
Prince-Metal is the same thing. Yep. Good
Okay.
question.
Thank you.
Good question, because I don't want you to get confused on little, little minute things like that, where it's like, oh, I would rather you ask than you miss the question because you didn't ask. Okay.
I have a question going into the new chapters. I just because I pull it up on the side too in case I get behind. What chapter are we starting with?
So this next week is gonna be 34 through 38 and 50 to 52. 34 starts endocrine. Yeah. So, and then is 50. And then 50 is renal. I almost want to start with renal. Because going from cardiac to renal is actually it's a nice transition. So I think I'm going to start with chapter 50. So we'll go 50, 51, 52, and then we'll go 34 through 38. Okay?
Can you say that again? You were breaking up.
Yeah, we'll start with chapter 50 today. Because we're going to go through renal and diuretics. And then we'll go into endocrine tomorrow.
Really quick question, real quick.
Yeah.
Are you able to tell us how many people failed your last class? Just so I have an idea, or no?
I think it was 3.
Okay.
I think.
So that's better
It was-
than like 10.
It was either 3 or 4. I don't remember if it was 3 or 4, but I'm pretty sure all of my ones that failed returned.
Okay. Thank you.
And I'm very happy to see you, by the way, all of my returnees. And they will attest that when they did fail, I was very, very sad. Okay. And then when I had someone fail because of math, I literally cried with them in my office while they cried.
I have a question. Well, when we do the math test, will it tell us the answers? Because sometimes mine will say 0 out of 10, and then it gets updated later.
So that was a problem with the first thing because the questions were put in wrong on Brightspace, like the weights were put in wrong. So that should not happen again. That was fixed. So yes, it should show you. You know what's funny? For the first time, I think ever, I feel like I'm talking to them more than I'm talking to you. And that's so odd to me. Because usually I'm talking to you guys way more than I'm talking to them. And then I have to look over here and I'm like, talk to me, talk to me, talk to me. Because they don't want to talk to me. So why are you guys quiet?
Oh, we're not, guys live there.
Amen. Did you hear her? She said, because we're not traumatized like them. They're very lucky.
Be grateful.
She said, be grateful. I think they are after hearing all of your guys' stories. I think they're very grateful. Okay, let's get started with chapter 50. Okay, so we have the functions of the renal system, which include composition of body fluids within normal ranges. So it's monitoring and maintaining hydration, sodium, potassium, all of the electrolytes that help regulate your volume, regulate vitamin D activation, regulating blood pressure through the RAS system, the renin-angiotensin-aldosterone system. Jesus. And then regulating red blood cell production through the production and secretion of erythropoietin, which we literally just covered. So the components of the renal system are the kidneys, and then the structures of the urinary tract are the ureters, urinary bladder, and urethra. Kaylee, we're on chapter 50. So this is the fun little kidney. I talk about the infrastructures of the kidneys a lot, right? So we have the adrenal gland up here, right? This is within our RAS system. This is where the aldosterone is released. This is where the erythropoietin is released within these adrenal glands that sit right on top of the little kidneys. Forgot, let me move you guys over here. Okay. We have the renal cortex, what does that say? Module? But within here, we have your nephrons. Within the nephrons are the glomeruli. Okay. And then within all of that is your little Bowman's capsule. And we're going to get all up in there when we talk about diuretics, because then you'll learn where those specific diuretics actually work within the kidney. Okay. And then this is your bladder. It's important to know that the kidneys go into the ureters. The ureters then go into the bladder, and then the bladder then goes into the urethra. Okay. So it would be an important thing for you to learn the particular anatomy of your renal system. So we have the nephrons, which is the functional unit of the kidney. This is where filtering fluid and making urine occur. You have the cortical nephrons and then the juxtamedullary nephrons. What was the other juxta word that we heard last week? Yes, and what are those? What are they within?
The kidneys.
Mm-hmm. They're part of the RAS system. The juxtaglomerular cells kind of kick off that negative feedback system within the RAS system, remember? Okay, so this is the infrastructure of the nephron. We have, I don't even know how many nephrons. I would say probably hundreds of thousands of nephrons within the kidney, okay? So within the nephron, you have your glomerulus, and this is a whole entanglement of vessels, okay? You have all of these tubules, okay? This around all of these vessels is called the glomerular Bowman's capsule. That's going to be an important structure for you to know, okay? Also, we have the ascending limb and the descending limb of the loop of Henle. That's also going to be an important topic when we talk about diuretics, because loop diuretics work within the loop of Henle. Okay? I hate that I have to use this mouse all the way over here. So you have the Bowman's capsule that surrounds the glomerulus, proximal and then the distal convoluted tubule, descending and ascending loop of Henle, collecting ducts and renal pelvises. I'm going to go more into some of those. The function of the nephron starts with glomerular filtration. This is where your GFR is from, your glomerular filtration rate. Okay. So the glomerulus acts as ultrafine filter for all blood that flows into it. So remember, we're talking about when we were talking about proteins and how big those protein molecules are. And when they are in the blood because of muscle breakdown from, say, rhabdomyolysis, right? That could happen if you take too much, or could happen from an adverse effect of statins. You're going to see that tomorrow, right? That can injure your glomerulus, right? Because those proteins are so big And the glomerulus is an ultra fine filter. And then you have this big old fat protein molecule trying to fit through that ultra fine filter. And then you have injury that occurs, which then can result in an AKI. Okay. You have tubular secretion, which is active transport systems that remove electrolytes, some drugs and drug metabolites, and uric acid. They secrete these into the filtrate. Then you have tubular reabsorption, which reabsorb water and various essential substances from filtrate back into the vascular system. So when things first get filtered, you have active transport that says, hey, I need more potassium. Oop, I don't need this much sodium. Oop, I need some of that magnesium. Oh, I think I need some of that calcium, right? And then on the other side of it is where you have reabsorption of electrolytes and water. Okay. The kidneys regulate composition of body fluids by balancing levels of key electrolytes. They secrete or absorb these electrolytes to maintain their desired levels. The volume of body fluid is controlled by diluting or concentrating the urine. Okay, so this is a constant balance. Hemostasis. Sodium regulation. Sodium is one of the body's major cations. It is a extracellular ion. We know that because it has a high range in numbers. What is the normal sodium level?
135
135 to 145. So sodium filters through the glomerulus and enters the renal tubule, actively reabsorbed in the proximal convoluted tubule to the peritubular capillaries. Am I going to test you on the specific whereabouts of blah blah blah? No, I am not going to do peritubular capillaries and proximal convoluted blah blah blah. What is important when we talk about drugs in the renal system is where the drugs work. That's when these parts are going to be important. Okay, like loop diuretics working at the loop of Henle. So when we talk about other types of diuretics, where those work within the kidney. Okay. Also reabsorbed via transport system under influence of carbonic anhydrase. Distal convoluted tubule further adjusts sodium levels under influence of aldosterone and natriuretic hormone. It's important to know what aldosterone does. Okay. So aldosterone, and we talk about that in our RAS system. So what does aldosterone do? When our brain tells the adrenal glands to release aldosterone, what does that cause our kidneys to do in the RAS system?
Retain sodium and water.
Okay. So aldosterone is going to retain water, retain sodium. So we have less urine output and more circulating volume, which also means more circulating sodium. So aldosterone is produced in the adrenal gland. It's released into the circulation as part of the diurnal rhythm. It responds to high potassium levels, sympathetic stimulation, or angiotensin 3, which is part of the RAS system. Okay. It stimulates a sodium-potassium exchange pump in the cells of the distal tubule, causing reabsorption of sodium in exchange for potassium. Remember, your sodium and potassium go like this. They're on a teeter-totter. So when your potassium is being reabsorbed and going up, that means it's excreting potassium. Okay? If it's going the other way around, and it's saying, I have too much urine, I have too much volume, I have too much sodium, we're going to secrete sodium and increase our potassium by retaining it. Okay? Which would be the opposite of releasing aldosterone. Sodium further regulated in the medullary nephrons in the loop of Henle. The cells are freely permeable to water in the descending loop. Permeable means how easily things pass through a structure. Okay, so if you're pouring water through a colander, it's extremely permeable. If you're trying to pour water through concrete, it's not permeable at all, right? So permeability is the level of way things are easily able to pass through it. So if something is more permeable, that means that things go in and out very easily. So water flows out of the tubule into this sodium-rich tissue to maintain osmotic balance, because what does water always follow? Water always follows salt. The ascending loop is impermeable to water, so water is not going in anywhere in there. It's impermeable. Water that remains is trapped there. Sodium, potassium, chloride actively are transported out. Antidiuretic hormone is important in maintaining fluid balance. It is released in response to falling blood volume, sympathetic stimulation, rising sodium levels. If it's present at the distal convoluted tube, the permeability to water increases. So let me see if I have a page number here. So this is all on page 904, right at the beginning of this chapter. And I feel like all of this is, when you talk about all the tubules and permeability and what goes in and what goes out, it can be very confusing to know what goes where and what's actually happening. So I do want you to read over this first chapter and really try to make sense of what this means, right? What does aldosterone do? What does the antidiuretic hormone do? So where are they released from? So your aldosterone is released from where? The adrenal gland. Your antidiuretic hormone is released from where? The hypothalamus, which it says on page 904, okay? And what those things are responsible for. And we're going to get into that even more with endocrine when we start that. For chloride regulation, chloride helps to maintain electrical neutrality with the movement of cations across the cell membrane. It is reabsorbed at the second half of the proximal convoluted tubule. It is actively reabsorbed in the loop of Henle and distal convoluted tubule, and it promotes the movement of sodium out of the cell. So what are our most important electrolytes? We need them all. But which ones, when they're screwed up, cause the most problems? Sodium and potassium. Magnesium comes in probably third. Calcium and magnesium are pretty, they're up there, but they're not as high as sodium and potassium. Then you have your chloride and your phosphorus that are just kind of hanging out, and they're not less important, but they cause less drama, okay? The more drama the electrolytes cause, the more imperative it is to keep them in check. And then they get kind of less severe from there. Potassium is vital to proper functioning of the nervous system, muscles, and cell membranes. Potassium is everything. I mean, it just is so important for every bodily function, specifically cardiac. So it is extremely important to regulate potassium levels. About 65% of potassium filtered at the glomerulus is reabsorbed at Bowman's capsule and the proximal convoluted tubule. So most of it is getting filtered and reabsorbed before it even gets to the loop of Henle. Okay. 25 to 30% is reabsorbed in the ascending loop of Henle. So 20 or a quarter of it is in the loop of Henle, which is where which type of diuretics work? The loop diuretics. So fine tuning occurs in the distal convoluted tubule. If levels are very high, retention of sodium in exchange for potassium leads to retention of water and a dilution of blood volume, further decreasing potassium concentration. What is causing this? What hormone is causing this? In the RAS system, aldosterone. Aldosterone is causing this. If levels are very high, retention of sodium in exchange for potassium leads to the retention of water and a dilution of blood volume. Aldosterone causes your kidneys to retain water, retain sodium so that it can release potassium. Calcium regulation is important to muscle function, blood clotting, bone formation, contraction of cell membranes like your cardiac membranes, and muscle movement. Absorption of calcium from GI tract is regulated by vitamin D ingested as part of the diet. You have to get vitamin D for calcium to be properly absorbed. Okay. Vitamin then must be activated in the kidneys to form to a form that promotes calcium absorption. Once absorbed, calcium levels are maintained within tight range by PTH and calcitonin, which is, we're going to cover that in endocrine, which all happens up here within the pituitary. Okay. Calcium is filtered at the glomerulus and mostly reabsorbed in the proximal convoluted tubule and the ascending loop of Henle. Fine tuning occurs in the distal convoluted tubule. Fine tuning occurs in the distal convoluted tubule for most of all the electrolytes. Okay. Nephrons and points of regulation of sodium, chloride, potassium, and calcium. So here is your glomerulus. This is your Bowman's capsule, which is surrounding that bundle of capillaries. We have the proximal convoluted tubule, which goes down. This is the loop of Henle right here. Okay. Then we have the distal convoluted tubule. So when we're talking about fine tuning, we're talking about all the way over here, where we're fine tuning those electrolytes. Okay. And this shows 65% of water, sodium, chloride, calcium, and potassium are reabsorbed here in the proximal convoluted tubule. Okay. And then we have more water, sodium, chloride, calcium, and potassium regulation in the loop of Henle. And then we have fine tuning of calcium, water, sodium, potassium within the distal. Okay. I know it's a lot. I really do. The body's mechanism for controlling the volume of body fluid involves the dilution or concentration of the urine. True or false? True. That is true. Why is it true? Because the kidneys regulate the composition of body fluids under the influence of various hormones like aldosterone or the antidiuretic hormone. By balancing the levels of the key electrolytes, secreting or absorbing these electrolytes to maintain the desired levels. The volume of body fluid is controlled by diluting or concentrating the urine. So it's all about what you're putting in and what you're putting out, which is why I's and O's are so important. Blood pressure control. I really hope that we're all at a point where we understand this concept. The RAS works to maintain blood flow to the kidneys. Renin is released when blood flow or oxygenation to the nephron is decreased. This activates angiotensinogen, which becomes angiotensin 1, which is converted into angiotensin 2. This causes vasoconstriction that raises the blood pressure, releases blood flow to the kidneys. So that's when it gets to the actual artery where you have vasoconstriction or dilation. Angiotensin 2 is converted in the adrenal gland to angiotensin 3, which stimulates the release of aldosterone. Aldosterone acts on the distal convoluted tubules to retain sodium and water, which then increases your blood pressure. So all of the drugs that work on the RAS system are working on different points at the RAS system. Okay. So this is literally just showing the RAS without all the pictures. So there's decreased blood flow and decreased oxygenation, which kick off our negative feedback system. Okay, which tells the juxtaglomerular cells, hey, I need you to release some renin. Renin is released, which activates the angiotensinogen, which then gets turned into angiotensin 1, which then goes to the lungs. And then the angiotensin 1 is made into angiotensin 2, which goes to the adrenal gland, which then goes to angiotensin 3, increases aldosterone, which causes sodium and water retention, which results in increased volume, increased blood pressure, and increased blood flow to the nephrons. We just talked about this. Erythropoietin is released from the juxtaglomerular cells when the blood flow or oxygenation to nephrons is decreased. It is the only known hormone that can regulate the rate of red blood cell production. It stimulates the bone marrow to increase production of red blood cells. In renal failure, production of erythropoietin drops, which leads to anemia. So erythropoietin is given when there is chronic kidney disease or something wrong with the erythropoietin natural production. We're not giving erythropoietin to someone who is deficient in iron. Vitamin D plays an important part in the absorption of calcium by the body. Where is vitamin D activated into a form that promotes calcium absorption?
C, kidneys.
C, kidneys. Vitamin D must be activated in the kidneys to a form that promotes calcium absorption. So after all of those fun things within the kidney, we then go to the ureters. One exists on each kidney. It drains filtrate from the collecting duct, so it drains the urine from the kidneys that was just made. Urine entering the ureter stimulates peristaltic waves, pushing the urine toward the urinary bladder. What is peristalsis?
How everything moves through the body.
Movement of the
What organs have peristalsis?
The stomach.
the intestines.
Yes. So we have a couple organs or structures that have peristaltic movements. We have the ureters, we have the esophagus, the stomach does have some peristalsis with active digestion, and then the intestines. The important part about peristalsis is that it keeps things moving in the correct direction. Okay? We don't want things to go backwards. When things go backwards, that is not a good thing. Okay? You never want urine to be shoved back into the kidneys from the ureters. You don't want poop getting shoved back from the intestines into the stomach. Food from the esophagus back up into your mouth, right? Peristalsis helps things move where they're supposed to be going. Okay? So then you have the urinary bladder, which is a muscular pouch that stretches and holds urine until excreted from the body. Control is learned over the external urethral sphincter. So we don't control necessarily the bladder, we control the sphincter that releases the urine. Okay. The urethra is a short tube leading from the bladder to the area populated by normal flora that can cause bladder infections or cystitis. What is the difference between a male and female urethra? Which puts them at more risk for
UTIs.
Right. So females have a urethra that's like 2 inches, 2 to 3, I think. Where a male can have a significantly larger urethra, which makes it much less common for men to have UTIs.
Hey, Miss Jessica, before you start that chapter, I just had a quick question about digoxin.
Go ahead.
You wouldn't give those special calcium channels like the verapamil and is it whatever the other med is? You wouldn't give those to somebody taking digoxin, right?
She said whatever that other med is.
I know it's 2 special ones. I just
Is it diltiazem?
Yes.
Yes.
Most of the time you're not going to give 2 antiarrhythmics, digoxin on top of verapamil or cardizem.
Gotcha.
I
And
don't
then what you
remember
would give
at
it.
this very specific moment if it's contraindicated.
Okay. And then what you would give if they were in like the toxicity, like the digoxin toxicity, it would be that DigiFab or that.
Yes, ma'am.
Is that? Yes. Okay.
Yep. All right, chapter 51, diuretics. So, diuretics most increase the volume of urine to some extent, the release of urine. Greater clinical significance is the ability to increase sodium secretion. So, most of the time, your diuretics are working on sodium excretion over everything else. The thing is, when you have sodium excretion, you can have different abnormalities with other electrolytes that go along with it. Okay. So most prevent cells lining the renal tubules from reabsorbing excessive proportion of sodium ions. Sodium and other ions are lost in the urine instead of returning to the blood. Indications for diuretic use: edema associated with heart failure, of course, acute pulmonary edema, liver disease, including cirrhosis. Now, this isn't going to do anything for ascites. Anybody know what ascites is?
Fluid in the like
Fluid in the
needle
stomach.
space.
Fluid in the stomach.
So ascites is caused from chronic liver dysfunction, and it is accumulation of fluid within the peritoneal space. And unfortunately, diuretics do not work for that fluid retainment because that fluid is outside of the organ system. It's just literally filling up the abdominal cavity. And diuretics work on the fluid that's inside the vascular system. Ascites is outside of the vascular system. Does that make sense? If you have pleural effusions, like you have a bunch of fluid in the pleural space, it's outside the circulatory system, which means diuretics are not going to touch that fluid. Okay. Also, renal disease, hypertension, decreased fluid pressure in the eye, which is useful in treating glaucoma, and conditions that cause hyperkalemia. A couple classes of diuretics would be thiazide and thiazide-like diuretics, loop diuretics, carbonic anhydrase inhibitors, potassium-sparing diuretics, and osmotic diuretics. There is only one osmotic diuretic. It's called mannitol. Mannitol is only ever given for increased intracranial pressure. It is not. It is contraindicated for patients who have pulmonary edema or heart failure. So this shows you the sites of action for diuretics. So carbonic anhydrase inhibitors work in the right before the descending loop of Henle. Your loop diuretics work within the loop of Henle. Spironolactone works right before the distal convoluted tubule. Thiazide and thiazides work within the distal convoluted tubule. So it shows you exactly where in the nephron they work. So thiazide and thiazide-like are slightly different chemical structures. They work similarly, but have identical indications for their use. So thiazide is your chlorothiazide and hydrochlorothiazide. A lot of these are used for hypertension. This is really kind of the only diuretic that's actually used for hypertension. You wouldn't really see others for that use. Thiazide-like would be chlorthalidone. These are not common. The thiazide-like, they are not common. You don't see them a lot out in the real world. Therapeutic actions, they block the chloride pump, which keeps chloride and sodium in the tubule to be excreted in the urine, and it prevents reabsorption of both in the vascular system. They're indicated for first-line management of essential hypertension, and other indications vary by the specific drug. So like I said, it's more for hypertension than really anything else. These drugs are well absorbed from the GI tract. They're metabolized in the liver, excreted. They cross the placenta and enter human milk, so they're getting to your baby. They are contraindicated, obviously, to an allergy to thiazides or sulfonamides. So if you have a sulfa allergy, you won't be able to take these drugs. Hypovolemia, obviously. Who's giving a diuretic to make you pee if you're already dehydrated and hypovolemic, right? Severe renal disease. There is, and we'll get there, but I want to make sure that I say it. When you come across a question that talks about end-stage renal disease and which diuretic that you would pick for end-stage renal disease, it's never going to be this guy, okay? Because it's contraindicated in severe renal disease. What are the best working diuretics that we see on a consistent basis in acute care? Lasix, which is what? Furosemide, which is
A loop
diuretic. So if you had a question that said you have a patient with end-stage renal disease, which diuretic are you going to give them, even though they're oliguric, which means they put out less than 400 milliliters of urine a day? It's going to be your loop diuretics because they work the best. They are the most efficient when it comes to urine excretion, even when your renal disease is very progressed. You want to use caution with thiazides with systemic lupus, glucose tolerance abnormalities, gout, liver disease, hyperparathyroidism, bipolar disorder, pregnancy, and lactation. Adverse effects are going to be GI upset, fluid and electrolyte imbalances. All diuretics are going to have an adverse effect of fluid and electrolyte imbalance. It's always going to be a risk when you're dealing with diuretics. Hypotension is always going to be a risk. Hypokalemia is always going to be a risk. Decreased calcium excretion, prolonged use can indicate, or I'm sorry, if you use this for a long time, blood glucose levels may increase. So that's something that is kind of special about this classification of drug. That's something that you would want to educate your patient, especially if they're a type 2 diabetic and they have trouble lowering their blood glucose. That's something you would probably want to let your patient know, like, hey, you're going home on hydrochlorothiazide. You're probably going to be on this medication long term for your hypertension. It could cause an increase in glucose over time. Okay. The drug-to-drug interactions would be digoxin, quinidine, anti-diabetic drugs, lithium, or other antihypertensive medications. Your digoxin and lithium are on this interaction list because what is special about digoxin and lithium? What do they need in order to perform correctly? Therapeutic levels. They need to have therapeutic levels, right? If you're on a diuretic, what does it put you more at risk for? With which electrolyte? That's very important. Potassium, hypokalemia. If you're hypokalemic, what does that increase your risk for? Digoxin toxicity, right? See how it all ties together? So this is just looking closer at thiazide diuretics. This is looking at hydrochlorothiazide. So it can be indicated for edema associated with heart failure, cirrhosis, corticosteroid or estrogen therapy, renal dysfunction, but not severe. Remember, not severe. Treatment as hypertension, and it can be combined with other antihypertensives. Remember, I talk about my mother-in-law all the time, right? She swears giving birth to my poor husband is what ruined her blood pressure because she's been hypertensive ever since she gave birth. And she takes metoprolol in combination with hydrochlorothiazide, in combination with something else that I don't remember, but it's a 3-in-1 kind of thing. So on the other page, it said drug-to-drug interactions can be with other antihypertensives, right? But that doesn't mean it's contraindicated. It can be given in combination with other antihypertensives. So your adverse effects include dizziness, vertigo, orthostatic hypotension. Why?
Because hypovolemia?
Yes, ma'am. Because of fluid depletion. What happens when you're dehydrated? You stand up too fast, you're like, whoa, I did not drink enough water today. Right? Hypokalemia and other electrolyte alterations, nausea, anorexia, vomiting, dry mouth, diarrhea, dehydration, polyuria, duh, it's making you pee. Nocturia. What is nocturia? Getting up at night to pee. Huh? Getting up at night to pee. Getting up at night to pee. Muscle cramps or spasms. What do you think the muscle cramps are from?
Low
Electrolyte
calcium?
electrolyte disturbance. So it could be low sodium, it could be potassium, it could be magnesium. You know, they're like, oh, my legs hurt. I need to go take magnesium. These are all essential in skeletal muscle movement. What do thiazide diuretics block?
A, chloride pump.
A, chloride. So chloride is actively pumped out of the tubule by the cells lining the ascending limb of the loop of Henle, and the distal tubule, sodium passively moves with the chloride to maintain electrical neutrality. How about a break before we get into loop diuretics? 10 minutes? 14 minutes. Come back at 1:10. Okay, so on ATI, I found a sorry. Laboratory reference ranges. I found this on ATI. And I want to put it on Brightspace, but I just don't know where I should put it. If I put it under week 1, I just want you guys to make sure you know it's there. So I guess I'm gonna do that.
You can make like a different sub tab, like where the weeks are, that just says like labs.
Yeah, I just don't want Christy Bowling getting mad at me for doing stuff. She likes to get mad at me. We're friends, by the way. And she likes to get mad at me for things. So let's see. So I go into student resources, add a assignment, create a file.
I had a quick question. Are we required to do anything before we're able to take the math test tomorrow?
No, there is no math module for this. But you
Okay.
do have to take your work sheet, the math practice tests. That is required. So I guess I
Okay.
lied. Yes, you have to do your math worksheet.
Okay. Thank you. That's not something we have to print out. That's just available in week 1, right?
Correct. And that grade
Okay.
goes right to me.
Okay, cool.
So I just put it on in the student resources tab and it's literally right at the top under materials. And this is straight from ATI, which means that it is concurrent with NCLEX standards. And it is all of your laboratory levels that you could ever dream of. Sure, there's more that aren't listed here, but you know what I mean.
I have a question.
Okay.
So, I know with some of the exams it'll say like the range. I don't know if you're able to tell us that or not. Like, does it
I
say
do
the
not do
range
that.
on your?
No, I do not do
What?
that. I do not do that. I want you to know it.
Gotcha.
The
Thank you.
NCLEX does do that, and I'm very happy for you. But at the same time, I can't sleep at night if I don't know if you know that the normal potassium is 3.5 to 5. Because then I'm just not gonna be able to sleep at night. Okay, ready? Will you close the door? Please. Okay, so let's get into loop diuretics. So they are literally named because they work in the loop of Henle. Your most common your most common ever is going to be furosemide, which is Lasix. Second most common is bumetanide, which is Bumex. And then third is torsemide. You'll see it once in a while. Definitely not as common as the other two. And then the fourth one you may never see unless you work in nephrology. So these block the chloride pump in the ascending loop of Henle, which decreases reabsorption of sodium and chloride. They're indicated and the drug of choice when rapid and extensive diuresis is needed. So these are your patients with significant pulmonary edema, significant peripheral edema, significant hypervolemia, okay? So rapid and extensive diuresis. This is your patient that came in with heart failure exacerbation that gained 40 pounds, and it's literally 40 pounds of fluid, and they are drowning in their own fluids. Okay. Acute heart failure, which is practically what I just described. Acute pulmonary edema associated with heart failure or with renal or liver disease, not ascites. And not really hypertension, but I mean, it could be, but is it often? No. No. It is metabolized and excreted, which varies by the drug. It's contraindicated for an allergy, of course. Electrolyte depletion, because it's going to cause more depletion. Anuria. What is anuria? Yeah, but what is the range? Anuria is less than how many mLs per day? Close. 30 mLs an hour is the standard for a human to make with healthy kidneys. So you're very close. It's 50 mLs per day. Anuria is characterized by the amount of urine of 50 mLs per day. The key there is day. Hepatic encephalopathy and pregnancy. You do not really want to remove fluid from a pregnant woman. It's not good for them. They need the fluid. You want to be cautious with lupus, systemic lupus, glucose tolerance abnormalities or diabetes mellitus, and gout. You want to be cautious with glucose because we lose glucose in the urine and could lead to possible, or in the flip side, when you're in long-term use, will cause retention of glucose, which can then lead to hyperglycemia. Adverse effects are related to the imbalance in electrolytes and fluid, hypokalemia, alkalosis, hypocalcemia, and like I just said, long-term use leading to hyperglycemia. Drug-to-drug interactions, aminoglycosides, anticoagulants, indomethacin, ibuprofen, salicylates, or other NSAIDs, digoxin, and lithium. Why these?
Does it have to do with their therapeutic range?
So there may be, this is on page 919 under clinically important drug-to-drug interactions. There may also be a decreased loss of sodium and decreased antihypertensive effects if these drugs are combined with indomethacin, ibuprofen, salicylates, or other non-steroidal anti-inflammatory drugs. These patients should be monitored closely. There is increased risk of digoxin toxicity if the medication administration causes hypokalemia. Concurrent use of lithium should be monitored carefully since hyponatremia could cause an increase in lithium levels. That's important to know. Just like hypokalemia is linked to digoxin toxicity, hyponatremia is linked to lithium toxicity. So not only does it have to do with the therapeutic levels, but it also has to do with the electrolyte disturbance that accompanies these drugs. Okay? Anticoagulation effects may increase if these drugs are given. So if loop diuretics are given with anticoagulants. And then aminoglycosides. One of the biggest adverse effects for Lasix, and this is something that I need you to remember forever and ever and ever and ever and ever, is that, have you ever given Lasix IV push? Okay. What are the drug administration directions? How long?
Push over a full minute.
It's usually 2 minutes, but definitely a minute. Do you know what happens to a person if you rapidly push Lasix? It can cause them to go deaf. Lasix is ototoxic, oto meaning ear. If you rapidly push Lasix, you can possibly cause hearing loss because it is ototoxic. Okay. If you give Lasix along with aminoglycosides or cisplatin, it increases the risk of ototoxicity. So on page 919 under adverse effects, ototoxicity and even deafness have been reported with too rapid IV pushing of these drugs. The loss of hearing is usually reversible after the drug is stopped. This may be an effect of electrolyte changes on the conduction of fragile nerves in the central nervous system. So it's very, very important that you know that and that you do not do this to your patients. If you do, I have had nurses say that they did this and they didn't realize the importance of it. And their patients literally said like, oh my God, my ears are ringing. Because it's actually in the moment affecting their hearing and their ears. So this is taking a closer look at furosemide. It is indicated for the treatment of edema associated with heart failure, acute pulmonary edema, and hypertension. It inhibits the reabsorption of sodium and chloride from the distal renal tubules and the loop of Henle, leading to a sodium-rich diuresis. So you are going to be putting out a lot of sodium with a lot of urine. Adverse effects include dizziness, vertigo, paresthesia, orthostatic hypotension, rash, urticaria, which is itching, nausea, anorexia, vomiting, hyperglycemia, hyperuricemia, which is why it is used in caution with patients that have gout, because gout is the accumulation of uric acid. So if this is causing you to have hyperuricemia, that means you're going to have an even more increased risk of a gout flare-up because of the increased uric acid. Urinary bladder spasm, ototoxicity, zebra, dehydration, and electrolyte alterations. Any questions on loop diuretics? Sounds like to me that loop diuretics are kind of the most important diuretic to that I need you to know. So carbonic anhydrase inhibitors, these are relatively mild drugs. These include acetazolamide, which is probably one of the only ones that you'll actually see in real life, but it doesn't happen a lot. The therapeutic action, it blocks the effects of carbonic anhydrase, which slows down the movement of hydrogen ions. More sodium and bicarbonate are lost in the urine. Have you guys discussed acid-base imbalances? Yeah. ABGs.
We didn't do the numbers or which way they go.
She said that we should go more of that complex care.
I love hearing that. That is my favorite thing to hear. I hear it all the time. They said they'd go over that in complex care. They said they'd go over that in complex care. And then you come to complex care and I'm like, you know this. And they're like, no, I don't. They told us we'd go over it in complex care. Okay, so when you see hydrogen, I want you to make a connection in your brain that hydrogen is an acid. More hydrogen means more acid. When you see bicarbonate, bicarbonate is a base. What does a base do? It neutralizes acid. So if hydrogen is acidic, bicarbonate is alkalotic. Okay? Our bodies are constantly balancing your acids and bases at every second of every moment of every day.
I have a question.
Go ahead.
Are the bicarbonates, isn't that some kind of stomach med? That sounds familiar.
So when you think about antacids, you think about things that neutralize acid. They are some form of base. So you have your sodium bicarbonate, calcium bicarbonate, magnesium bicarbonate. These are used to decrease acid production within your stomach because your stomach is full of hydrochloric acid. Okay. Hydrogen, hydrochloric acid. See what I did there? So every time you think of hydrogen, you think of acid. When you think of bicarb, you think of neutral, base, alkalosis. Okay? The kidneys are responsible for your metabolic acid-base balance.
You said bicarbonate for base, right?
Yes.
Okay, just wanted to confirm.
So, if I just told you that these drugs slow down the movement of hydrogen ions, so it slows down the movement of acid, and then it increases the loss of bicarb in your urine, what do you think you would be at risk for? Acidosis. Because there's too much acid and not enough base. Okay? This is what we call metabolic acidosis, which is a risk when you're dealing with the movement of acids and bases. Okay? These can be used in adjunct with other diuretics, and also glaucoma, which is a reason that you don't see this a lot in the hospital. You see this as in eye drops because patients with glaucoma take eye drops like 2-3 times a day. And it can be depending on the eye and how severe it is. It can be in the left eye 3 times a day and the right eye 2 times a day. It just depends on their treatment. So this is rapidly absorbed and widely wildly. I keep doing that. Widely distributed, excreted in the urine. It is contraindicated in non-congestive angle closure glaucoma. There are two types of glaucoma, open angle and closed angle. So this is saying it's contraindicated in one of them. It's important.
I have a question.
Uh-huh.
If it's slowing the movement of hydrogen acid, why wouldn't it be at risk for alkalosis?
Because it's excreting all of the base. So if you go back, it's saying that the sodium and bicarb are lost in the urine, which means it's being excreted faster than the movement of hydrogen ions. So if you're losing too much base, it is going to put you at risk for acidosis. Metabolic or respiratory, which we're not going to get into right now because I'm just glad we got to even start on acid base and that the lungs and the kidneys are responsible for your acid base balance. At least you have more than the students that I just taught who didn't have anything about acid base. Okay. So you want to use in caution with patients that have fluid or electrolyte imbalances, renal or hepatic disease, adrenocortical insufficiency, respiratory acidosis, and COPD, because it can make your acidosis worse. Adverse effects are related to disturbances in acid base and electrolyte balances. Metabolic acidosis, like I just said, hypokalemia, paresthesias of extremities, confusion, and drowsiness. Drug-to-drug interactions are salicylates, medications that could cause metabolic acidosis, and medications that lower potassium. So if you are already at risk for metabolic acidosis, or you already have metabolic acidosis, you don't want to give them more drugs that are going to cause metabolic acidosis. Okay. This is all on page 920. Yeah. Metabolic acidosis is a relatively common and potentially dangerous effect that occurs when bicarbonate is lost. Hypokalemia is also common because potassium excretion is increased as the tubule loses potassium in an attempt to retain some of the sodium that is being excreted. Patients also report paresthesia, which is known as tingling of the extremities, confusion, and drowsiness, all of which are probably related to the neural effect of the electrolyte changes. So when you have tingling of the extremities, confusion, drowsiness, this can be caused by hypocalcemia. This can be caused by hyponatremia. There is a higher risk of salicylate toxicity with these medications due to the potential of metabolic acidosis. What is salicylates? Does anybody know? I keep saying that word, huh? It is aspirin. Aspirin is a salicylate. So, therefore, high-dose aspirin is contraindicated and patients taking low-dose aspirin should be monitored carefully. Who takes low-dose aspirin? Everyone above the age of like 45 or 50. Any medication with the potential of causing metabolic acidosis could have an additive effect, or I'm sorry, additive effect with these medications. Concurrent administration with medications that lower potassium should be monitored carefully. So what other drug are we thinking about with hypokalemia that the patient is at risk for? That's going to be on your exam tomorrow. Hypokalemia increases your risk for what toxicity?
Digoxin toxicity.
Digoxin toxicity. So, if all of your diuretics are putting you at risk for hypokalemia, we want to be extremely cautious for patients that are taking digoxin because hypokalemia will increase the risk for digoxin toxicity. Potassium sparing diuretics. These are not as powerful as loop diuretics. None of them are, by the way, as powerful as loop diuretics. These retain potassium instead of wasting it. Your most common drug is spironolactone, which the other most common name for it is aldactone. So this causes a loss of sodium while retaining potassium. Excuse me. Spironolactone and allopurinone are aldosterone agonists. So when your adrenal glands release aldosterone, it causes an increase in water retention, an increase in sodium retention, and an increase in potassium retention. Or I'm sorry, depletion. Okay. So your potassium sparing diuretics are aldosterone agonists, which means they work the opposite way. They release sodium and hold potassium. Make sense? So your agonist is working against, it's doing the opposite. Indications are patients who are at risk for hypokalemia, adjunctive treatment of edema. It has shown some improvement survival for patients with heart failure, and spironolactone is the drug of choice for hyperaldosteronism. You are hyper secreting aldosterone. What is happening to your potassium? It's going down. So spironolactone is the drug of choice for hyperaldosteronism because it is a aldosterone agonist. So it's going to be the opposite. It is going to stop and manage the loss of potassium. Make sense? So these are well absorbed, protein bound, widely distributed, metabolized in the liver, primarily excreted in the urine. It does cross the placenta and enter human milk. Contraindications would, of course, be hyperkalemia. If we have too much potassium, we don't want to spare it. I want to get rid of it, right? Severe renal disease or anuria. So that's the second diuretic that we've gone to that is contraindicated for anuria, right? So you want to be conscious for the use during pregnancy. Adverse effects, of course, are going to be hyperkalemia. When you're hyperkalemic, what are you at risk for?
Arrhythmias.
Arrhythmias, dysrhythmias, cardiac arrest. Very important for you to know for the rest of forever. Remember the drug-to-drug interactions with salicylates? And then other medications that block the renin-angiotensin-aldosterone pathway. What drugs are those?
You said blocks what?
The ACE inhibitors.
ACE inhibitors. ARB. Good. Good. Yes. Okay. These drugs work on the RAS system. The RAS system involves the production of aldosterone. Okay. So you want to use caution when you're already messing with aldosterone. Okay. And that risk is increased risk of hyperkalemia when used with other medications that block the RAS pathway. Okay, so this is just taking a closer look at spironolactone. The indication is for primary hyperaldosteronism, adjunctive therapy in the treatment of edema associated with heart failure, nephrotic syndrome, ascites associated with cirrhosis, which is only going to be slightly helpful, right? Because it's only going to help with the blood that's circulating through the liver, not that's in the peritoneal space. Okay. Treatment of hypokalemia or prevention of hypokalemia in patients at high risk, like a patient that's also taking a loop diuretic or has hyperaldosteronism. Adverse effects, they're really, most of these drugs, they're all the same, except for Lasix has ototoxicity, right? But they all say dizziness, headache, drowsiness, rash, cramping, diarrhea. This one, instead of hypokalemia, is hyperkalemia. So that's obviously one of the most important things because it's potassium sparing. Hirsutism. What is hirsutism? Bearded ladies. It's hair in places it's not supposed to be. Hirsutism is the growth of hair in places that is not supposed to be. Gynecomastia, that is a zebra. What is gynecomastia? Gynecomastia is the development of breast tissue in men. This is the hyperdevelopment of breast tissue in men. Men and women both have breast tissue. That's why men can absolutely be diagnosed with breast cancer, but they don't form breasts. Gynecomastia, you have a man that is forming breasts. Okay. So this would be a huge risk factor for a boy during growing and puberty years. That's probably not a good idea. But deepening of the voice and irregular menses. True or false? Loop diuretics cause the body to excrete copious amount of potassium-rich urine. Tis false. Loop diuretics block the chloride pump in the ascending loop of Henle, where 30% of all filtered sodium is normally reabsorbed. This action decreases the reabsorption of sodium and chloride. The loop diuretics have a similar effect in the descending loop of Henle and in the distal convoluted tubule, resulting in the production of copious amounts of sodium-rich urine. Osmotic diuretics, we already kind of touched on this a little bit. The only drug available is called mannitol. Therapeutic action, sugar that is not well absorbed by the tubules. It pulls large amounts of fluid into the urine due to the osmotic pull. The indication is in acute situations when necessary to decrease intracranial pressure. intracranial pressure. Mannitol is never going to be the answer when you're talking about heart failure or pulmonary edema. Ever. The only time that it is used for acute renal failure is shock. So it's very specific. But it is indicated 9 times out of 10, 99 times out of 100 for to decrease intracranial pressure. So it is freely filtered at the renal glomerulus, poorly reabsorbed by the renal tubule, resistant to metabolism, not known if it causes fetal harm. So we're not really giving it to pregnant people. It is contraindicated in renal disease and anuria. Contraindicated in pulmonary congestion, intracranial bleeding, dehydration, heart failure. You are never, ever, ever, ever giving this diuretic for any of these things. What is mannitol used for? Decreasing
to relieve intracranial pressure.
Intracranial.
Please remember it forever. Please do not miss this question or I will be very upset. Very. I'll be very bad. So we want to use this in caution with pregnancy because, like they said, we don't really have any research on it. Adverse effects occur from fluid shifts, which may cause heart failure and pulmonary edema. So why can't we use it for patients with heart failure and pulmonary edema? Because it causes it. It will make it worse. Hypotension and dehydration, CNS toxicity, nausea, vomiting, lightheadedness, electrolyte imbalances, infusion site reactions, and headache. How do carbonic anhydrase inhibitors work?
D.
Slow down the hydrogen ions.
Which puts our patients at risk for acidosis. Yay! Okay, so we have about 40 more minutes. I got people packing up. Okay. I'm like, what's happening? Do you want to finish chapter 52 or do you want to go over math?
Math.
All right, I want to vote. Put in the comments math or 51. 52, I'm sorry, 52. And what's our vote here? Raise your hand for math. 1, 2.
I don't care either way. I'm gonna go.
Oh, so I got a bunch of Switzerlands.
I
got a
guess I would say
lot of
math
math.
because I feel like it would be better to kind of like not take in so much information pertaining to tomorrow's. You know what I mean? Just it's a lot of information when we have another test. You know what I mean? So I think it might benefit us to not take in any more information.
It would be so much. Yeah, we'd have so much to do after the test.
Yeah, we have less time tomorrow. We're only in lecture from 11:30 to 2.
Yeah, but then we have Monday.
Yeah, but then it's the day before the test.
I know, but majority rules. And like I said, I would be so excited to be able to brag about all of you that you passed your math on the first attempt. Just saying. Just saying. All right, let me go get my camera thingy so you can see what I'm writing.
When you have a moment and
Mhm.
we go over the conversions, I'm having difficulties because I'm old, so I'm stuck in my ways.
You said I'm
When when we do like the MCGs to G's or grams, can we talk about that? Like how you have to figure it out one way and then you have to go back and divide or multiply by a million and yeah.
Who was the people from last week? We were talking about the King Henry thing. Was that right? Who was that?
Yeah, I have
I
that
do it that
already.
way.
I have that written down.
That was me. Nothing.
Yeah. I got that and I've looked over it and I think it's because when I look at it, it doesn't look right to me. And I'm like, well, that can't be the answer because we wouldn't have an answer like that. But then Miss Ange was like, just remember this is for test purposes only. And I don't know.
I don't know what she means by that. Is she talking about the ones where it's like 0.002
Yes.
something like that? Yeah. Then
Yeah.
she, in that instance, she would be correct. It really truly is for test purposes. Because I mean, even in probably like even like the NICU, you probably would never give a medication that small.
Yeah.
And if you did, it would truly only be within like a NICU, very teeny tiny baby situation. So it really truly is just about the conversion of that number and being able to convert. So she is correct, is that it is not really real life when you're talking about such a very small, minute number. But, okay. So, did everyone do the practice math worksheet?
Working on that.
She said working on that. I have 1, 2, one, 2, 3, 4, 5, 6, 7, 8. 8 people that have not even attempted it yet. That makes me mad. Why you do that to me?
Because I need to focus on the content versus the math.
But I need you to pass math. Okay. See my paper?
Yes.
So we have 5,600, and we all know that we are not putting commas in our answers. I want you to know it and say it to me, because I'm not going to see anybody put
I know that
commas in.
now.
Nope.
I put commas on one of mine and it said I got it wrong.
So please don't do that. Okay. So we are going from 5,600 grams to milligrams. So we're going from big to, well, I mean, really, if you want to think it's like big to small, but it's going to be a very big number because you're multiplying this by 1,000. Okay. Because what you're doing is you're breaking this down into more pieces, which is going to give you a small or a larger number. Okay. So this is going to be 5,600 times 1,000. Which is going to give you what? Now remember, you don't have commas, so you need to count your zeros. Because if you miss a zero, you're going to miss the question. So I want to make sure, yeah, I don't have a comma here or a comma here, but I'm making sure it's 5,600,000. So 600 has 2 zeros, 1,000 has 3 zeros. I got 1, 2, 3, 4, 5 zeros. So make sure when you're putting that answer in, you're putting in your zeros. Okay. So does that make sense where, yes, you're going from this number to this number, but when you're breaking it down, you're going to have more pieces. So if I have 5,000 pieces and then I want to break them down even more, I'm going to have more smaller pieces. So I got 5,000 rice patties, and then I want to break it down into individual rice. Does that make it worse? I don't want to make it worse. And rice patties was the first thing that came to my brain because I love rice patties. So you have a big old fat rice patty that has 1,000 pieces of rice all stuck together. And then I want you to give me the number of each individual rice inside that patty. So I'm going from bigger to smaller, but smaller means I have more pieces. Nobody's talking to me. And I feel like if I keep talking, I'm just going to make it worse. All right. So then we have 3,200 micrograms, 2 grams. So we're going the opposite way. So with this way, we were going from milligrams over here, or I'm sorry, from grams to milligrams. So you had 5,600, and your decimal point is here, and you're going this way. So you're going 1, 2, 3, which is giving you 3 more zeros, moving your decimal point. Okay. But with this one, we're going this way because we're going the opposite way. But don't let it fool you because we're going from micrograms to grams, which means we have to convert twice. Right? We're either going to divide by 1,000,000 because that's how many micrograms are in a gram, or we're going to divide by 1,000 and then divide by 1,000 because we are converting twice. Because you could say, okay, well, if I'm converting micrograms to milligrams, I'm going to divide by 1,000, and that gives me, however, 3.2 milligrams. And then I'm going to divide it by 1,000 again, which is going to give me 0.0032 mics.
Excuse me, Jessica, we are putting a decimal though for that. It's gonna be 0.0032.
Oh yeah, always. So there's a difference between a leading zero and a trailing zero. A leading zero, you always have to have a leading zero. Okay, this is a leading zero. This, if you did 5.60, this is a trailing zero. This is a no. This is a yes. How do we feel about that?
Good.
No,
She said no. Who said no?
no, I did.
Well-
Chastity. Okay, can you explain to me just what, however, why for this one? Because it's, what is it, micrograms to grams. Can you please explain to me why we are dividing it by 1,000,000? I just need to hear you say it. Does that make sense?
Okay. So you see with the first one, you're going from grams, which we already have the grams. We already have them. And we're going to milligrams. So we're going one way, which is multiplication.
Mm-hmm.
Okay. So when you go from micrograms, which is what we have, to 2 grams, we're going the other way, which
Which
is
we're dividing.
division.
Yes.
Okay. So now
Mhm.
you're saying, why is it 1,000,000?
Yes.
Okay. So it's 1,000,000 because, let's make sure I'm right before I say it out loud. A 1,000 times 1,000 is 1,000,000. So remember, I said you could break it down twice if you wanted to. You could say, okay, I have micrograms. I'm going to grams, so I can go to milligrams first. I can do it twice. I can say, okay, I have 3,200 mics to milligrams. So I can say, okay, I know I'm going to divide that by 1,000, which is going to give me
3.2.
3.2 milligrams. But I'm not looking for milligrams, I'm looking for grams. So then I would have to divide it again by 1,000 to get grams. Because I'm moving 2 spaces. I'm not just going from milligrams to grams or micrograms to milligrams, right? I'm going from micrograms to milligrams to grams. So I'm moving 2 conversions.
Okay.
Does that make sense? She's
Yeah.
like, no, not really.
It's good. It's good enough. It works for me.
It's
I'll
good
just, I'll just divide it twice by 1,000
That's fine. However you want to
instead
get
of
there.
thinking like 1,000,000. You know what I mean? Like because again, to me, it just doesn't look right, and then so I backtrack on myself, and I'm like, no, that's not right. It don't look right. But just because something doesn't look right doesn't mean it's not the correct answer.
Correct. Very much so. Correct. All right,
Thank
so
you.
then the next one, you're welcome, is 2,600 milliliters to liters. So which way are we going? Are we dividing or multiplying? We're dividing. So we are going 2.6 liters. All right, so then the next one, what is the abbreviation for normal saline? 0.9% sodium chloride.
Yes.
Okay,
And
so then what is D5W? Mm-hmm. Are you putting answers in the chat? Yes. Okay, I couldn't see, I didn't have my glasses on. So say it out loud, what is D5 or D5W?
5% dextrose.
Dextro and 5% water.
Water.
Well, no, it's
5%
dextrose,
dextrose.
5% in water. So there's 5% of that water is dextrose. It's not 5% water, it's 5% dextrose. So D5W is dextrose 5% in water. Okay. And then what is LR?
Lactated ringers.
Lactated ringers.
Lactated ringers. What is 0.45% sodium chloride?
Half NS.
Half NS. Okay. What is what is it? Is it 0.225 sodium chloride?
You got us on that one. I don't know.
It's 0.25%. It's 0.25%. You don't really see that often. It is 0.25%. Okay, so a provider prescribes furosemide 80 milligrams POTID. So our order is 80 milligrams POTID. What is TID? 3 times a day.
3 times a day.
Available, I have 40 milligram tablets. And 80 milligrams. Oh, sorry, 80. Sorry, I forgot the 0. How many, first of all, that verbiage is wrong. How many tablets per dose? So we're looking for tabs per dose.
2.
So this is going to be 2 tablets, which we are not labeling, right? We're not labeling because then it makes it wrong too. So 2, the answer is 2. All right, a nurse is preparing to infuse D5LR 1000 over 5 hours. What is the milliliters per hour? So our order is D5 1000 milliliters over 5 hours. What is the milliliters per hour? So these really are the easiest ones because we already have all of the things we're looking for. So it's really just 1,000 mLs over 5 hours, which is equal to what?
200
milliliters per hour. Okay, so a nurse is preparing to administer digoxin. 0.25 milligrams IV. Available is 500 micrograms per ml. So we have a conversion in our midst. How many mLs should the nurse administer? So first we need to convert which one?
The mgs.
The milligrams to
Convert
micrograms.
micrograms into
Hours to minutes.
So I would definitely convert my mics to milligrams. So it would end up, sorry, I'm looking at my screen. So we have 1 ml, that's equal to 500 mics times 1,000 micrograms, which is equal to micrograms, which is equal to 1 milligram, which our dose ordered is 0.25 milligrams. So we know we did our dimensional analysis correctly because milligrams cancel milligrams, micrograms cancel micrograms. So then we need to do some math. So 1,000 times 0.25 is 250 divided by 500, which is a very, very long way to get to 0.5 mLs. But that is the entire dimensional analysis. Could you convert outside of your dimensional analysis? Of course you can. Of course. Did everybody get that answer?
Yes.
If you did not, tell me so that we could figure out why you did not get that answer. Okay. All right, so our next one, a child weighs 38 pounds, 10 ounces. What is the child's weight in kilograms? So first of all, we need to convert the ounces into pounds. Okay. So how do we figure out the 10 ounces?
Do you divide it by 16?
Okay, so what would that give you?
0.625, which would be 0.6.
Don't convert.
Never convert in the middle
No.
of the problem.
Round.
Or I'm sorry, round. You never round in the middle of a problem. That's going to change your final answer and then you will get it wrong. Okay? So if 10 ounces is equal to 10/16 of a pound, which is 10 divided by 16, which equals 0.625, that means we're going to have 38.625 pounds. Now we need to find out the kilograms. So now we have, oh, I'm sorry, that I keep writing my numbers wrong. Don't do that tomorrow. So 38.625 divided by 2.2 is equal to what?
17.55. Just
17.55, which equals 17.6, because we are rounding to the nearest tenth, which is in, make sure you read the directions, okay? As it says, please round to the nearest tenth. Did everybody get that answer? So who was it that wanted to round to 38.6? Okay, I guess you don't have to point yourself out. But if you did that, 38.6 divided by 2.2 would have given you 17.54, which would have given you an answer of 17.5, and you would have gotten it wrong. Okay, so you never round in the middle of a problem, right? All right. A nurse is to infuse 500 mLs over 4 hours with a tubing calibrated to 20 drops per ml. How many drops per minute are you giving? So we have drops per minute. So we have 20 drops is equal to 1 ml times 500 mLs over 4 hours times 1 hour over 60 minutes. Can you convert this 4 hours to minutes? Absolutely. So it can look like this, or it can look like this. Both are correct. Okay. And that is going to give us 20 times 500 is 10,000 divided by 240. $41.666666, which is going to give us what? 42, because you can never cut a drop in half. Okay? So drops per minute are always rounded to the whole number. Two more. All right, a nurse is preparing to administer clindamycin, 150 milligrams PO Q6. How many mLs should the nurse prepare per dose if the medication is diluted per the directions below? Oh, okay. Well, the directions below say that when reconstituted, each 5 mLs has 75 milligrams. So our order is 150 every 6 hours. How many mLs should the nurse prepare per dose? So we're looking for mLs. We have 5 mLs, that's equal to 75 milligrams times 150 milligrams, because that's our order. So 5 times 150 is 750 divided by 75 equals 10. So the answer is 10 milliliters per dose. Okay. All right, number 9, a nurse is preparing to administer azithromycin to a child who weighs 50 pounds. The medication reference recommends 10 milligrams per kilogram PO daily. How many milligrams per dose should the nurse administer? So it is 10 milligrams per kilogram. The child weighs 50 pounds, which is how many kilograms?
$22.8.
22 point, no,
Are you?
you don't round in the middle of a question. Okay, so you would find this answer, which is 22.7272727272. Okay, And then it's saying that it's 10 milligrams per kilogram. So now at this point, all I need to do is multiply this by 10 because I'm looking for milligrams. So I'm going to times by 10, which is going to give me 227.27272727. And I'm going to round to the nearest tenth, which is going to give me 227.3. Milligrams per dose.
Miss Simmons.
Did they, they put 227, didn't they? As the answer. When you took your practice test. Did it say the answer
This wasn't on our practice test.
I think these are different.
Yeah, these are.
Yeah, this wasn't on.
This is the.
We didn't have the weight ones.
Yeah, we didn't have this one.
Okay.
This wasn't on the worksheet.
All right, hold on. No, it wasn't. It was drops per minute. Well, good. That makes things even easier. No, there wasn't. I was looking at the one in the drive, which is not the one that's on Brightspace. I was just looking at the one in our like Google Drive, which it should be the same, but it's not. That's fine. It's fine. But at least we're practicing. Practice makes perfect.
Are you able to send us that one though, so we can practice questions like that, just in case?
It's not. Believe me, it will not be on your exam tomorrow.
Oh,
I promise.
okay.
I promise you that. I promise you that. Listen, the worksheet that you did on Brightspace, okay, is the exact same as the exam that you are taking tomorrow, just with different numbers. I cannot make that as clearer than that. And you bet your bottom dollar that when we walk out of this room, I'm going to double check it and make sure because I do not like being wrong if you haven't noticed. So trust me when I tell you that the exact worksheet is going to be the exact same as your exam, but with different numbers. Okay, so you will obviously have different answers. So number 9 on the on Brightspace is normal saline 1,000 milliliters over 8 hours with 15 drops per ml. That's what's on Brightspace for number 9. So we're looking for drops per minute. So we have 15 drops per 1 ml times 1,000 mLs over 8 hours times 1 hour over 60 minutes. And I know I did it right because I'm left, I have hour, crossing that off, ml, ml, and I'm left with drops over minutes. So 15 times 1,000 is 15,000. 8 times 60 is 480. Which gives us 31.25, but it's a drop. So we're rounding to the whole number, which is going to give us what?
31.
31 drops per minute. Okay. And then the very last one on Brightspace was 200 mLs over 1.5 hours with 15 drops per ml.
$33.
Yeah, but let's do it the long way.
Oh, sorry.
$15 drops per 1 ml times 200 mLs over 1.5 hours times 1 hour over 60 minutes. That gives us 3,000. Over 90. Which equals 33.3333333333, which equals 33. And that concludes our lecture. Does anybody want to stay on and go over more math?
Not math per se. I'm sorry.
Well, I can't do a test review with only half my class.
No, I know. I just
Okay,
pray
if
that
it's a
your
test
voice
review,
now.
my brain will be ready for that, but I can't do any more math.
Can't do any more math. That's okay. I really, really, really want you guys to do well tomorrow on your math exam.
Could you send us maybe like a few, like from your own wording, like a few
More
exam
math?
questions? No, just like the regular exam questions.
Are you for serious right now?
No, I'm not asking like from the exam itself.
Are
just
you
how...
for serious? Just like a roundabout, like not
Well, no,
that.
because I get what she's saying. Because like when we have a different teacher every month, we don't know what to expect from that teacher until we see their first exam. And I think I get that's what she's saying. It's like, could you show me an example of how you ask questions? Because every single teacher asks questions different.
Just like the
I get where she's
format.
coming from, because that is like my biggest anxiety before going into the first test.
Okay,
And like I make up my own questions.
I'm out. That also depends on the type of question you're even talking about. Like,
Okay,
is it
so
is
maybe
it a question of application? Is it a question of evaluation? Is it a question of implementation? Like all of those factors change the way a question is worded.
okay, like could you give us maybe like a question for something about ARBs? Maybe throw that to me real quick, so then I can plug that in and make my own question so I can practice, or maybe calcium channel blockers.
I wouldn't. First of all, you can't take away points on ATI. That's impossible.
They told us that they would never go down. They either
Never.
stay
You
or
can
go
never go down.
So you do the analytics you said before we come back from the thing.
Yeah, unless something happens and I need to get out of here.
Unless you're busy, I get it.
Yeah, unless my child needs me, or my husband needs me, or God forbid the mother-in-law.
Yeah, I get it. I have 5 kids.
There's no reason why I
Got
should
the
be
mother-in-law.
this. Oh, listen, I'll bitch about her all day, but she's my best friend. So
My mother-in-law is a nurse, or was a nurse. She just retired like 2 years ago. So she's been like my biggest cheerleader through this all. If I get a 76 and I'm all hype about it, she's like, well, why wasn't it an 86?
Yeah.
And I'm like, Janine, we want a 76.
Janine
in a Foley. Mary, who's my mother-in-law, she was the first person I called because she was a surgical tech for like 20 years. And also she's just like, she'll hype you up over anything, even if she doesn't even know what it means. And I called her and I was like, Mary, I put in my first Foley today. And she was like, oh my God, that's so funny. So, okay, let's see.
I have a question about a topic too. Notes, I don't know if I'm saying it right,
Hold
the
on,
bile
Bonnie.
acid. Oh, okay.
I was Charlie said in the chat, she asks questions almost the exact same way she goes over something in class. She doesn't use too many trick questions, just have to read the question carefully. That is very true. So there are things about questions that are just basic test taking strategies. Like if a question has the word severe, your patient is having a severe response to something, okay? It could be a number of things, but if that word severe is in your question, you're not monitoring anything. You're not waiting. You need to do action. If your patient is experiencing a severe reaction to something, a medication, whatever is happening, there is no, I'm going to monitor and wait. There is, I am notifying a physician. I am getting a medication to help whatever is happening. I am doing something. The word severe calls for action.
Do we assume we have the order if
assuming.
Well, listen, I'm on our last proctor exam practice, not for this class, but for the previous one we did. I got an answer wrong because it said give analgesic for pain, but it never said anywhere in the question that there was an order for analgesic for pain. So I assumed that I should notify the provider because I don't have an order. And she said, no, you need to assume you always have the order.
Okay, so let me give you an example. And Bonnie, I didn't forget about you, I promise. Let me give you an example. There's a question in complex care that I ask about a post-operative patient that is having difficulty with deep breathing exercises. And the response, like the options are to let the patient rest and try again later. Tell the patient that they need to try harder. And then I don't remember the fourth. Yeah, Brandy, you're allowed to log off. I don't remember the fourth. But the third option was provide the patient with pain medication and come back 30 minutes later to try again. So the key is that the patient was post-op from a CABG. So a coronary artery bypass graft, which means that patient just had open heart surgery where they literally cracked his sternum. Okay. So assuming is not the same as knowing what the procedure is. So I know that if I crack your chest open and break your ribs and your sternum while you're having open heart surgery, you're going to have a lot of pain in your thoracic cavity, and moving your lungs in expansion with inhalation and exhalation is going to be extremely painful. I'm not assuming that. I know that, right? So I then need to come to the conclusion that my post-op patient from a open heart surgery needs to have their pain adequately managed for them to be able to breathe properly. So the answer is going to be they need to be medicated for pain and we need to come back 30 minutes to an hour later and try again. Because what happens if you say, oh, you can rest and you can, you're fine, and we'll try again some other time? What is that putting your patient at risk for?
Pneumonia, PE, DVT.
Why? Why
Because they're
pneumonia?
not moving. There's no circulation. They have
No.
poor circulation.
No, pneumonia specifically. Why pneumonia in a post-operative patient? Because of the risk of atelectasis. Atelectasis is the collapse of the alveoli. Because of a patient being on a ventilator during surgery, it puts them at a higher risk for injury and atelectasis. So it is imperative for a post-op patient to use incentive spirometry, which is deep breathing exercises with the incentive spirometer, to decrease their risk for atelectasis and overall decrease their risk for pneumonia. You see how much we just went through? I'm not assuming anything. I'm not making anything more than it is. The question was simple. My patient is post-op from a CABG. He's unable to participate in deep breathing exercises. What do I, as the nurse, need to do for him? I just gave you a whole situation, but it's not because I assumed anything. It's because I've learned that this patient is going to have pain from an open chest surgery. I've learned that my post-operative patient is at high risk for atelectasis. I've learned that atelectasis puts my patient at a higher risk for pneumonia. I've learned that in order for me to prevent post-operative atelectasis and pneumonia, my patient needs to be using incentive spirometry and deep breathing exercises. So you see how I'm doing this, where I'm not talking about assuming anything about my patient. I'm just using all of my little pieces of knowledge and connecting them into one piece to make my puzzle whole.
Alex.
All right.
Alex.
What? Oh, Bonnie, what's your question, girl?
So I was a little confused on the bile acid
sequestriants.
How do you say it?
Sequestriants.
Sequestriants.
Yeah.
Sequestrants. So I know that it has like GI irritation and aggravated hemorrhoids. And then the only other thing that I know about it is that it interacts with the diuretics, digoxin, warfarin, and stuff like that. But I didn't know like if I was missing anything from.
Miss Bonnie, you sure are. And that means that you need to go back into my lecture where I talked about bile acid sequestriants and listen to what I said, because it is much more than that. And maybe one of your friends will help you and have the answer.
Okay. Yeah, I have more notes than that, but those were the only things that I marked as important. So I have like, do not take if there's abnormal intestinal function or biliary obstruction, but I'll go back and look at the PowerPoint.
So none of what you said, and I'm not trying to be a jerk right now, I promise. None of what you said is what I want. And it's not what I talked about was important in my lecture. Somebody help her out. What's the answer?
Okay, what was the question that you were asking about it?
About bile acid sequestrants.
Yeah, I was missing information about the bile acid sequestrants.
Who has it?
Okay.
I think what she's looking about like the time of taking the meds, if they're on anything else, like a contraceptive or like a thyroid hormone or a steroid or something like that. They're supposed to take those
that was
1
the
hour.
bile acid resins though.
You're supposed to
No,
take it
it's-
7 hours before or after other medications. And it
You're all
blocks.
talking about the same exact. You're all talking about the same exact thing. They're called bile acid
Yeah.
sequestrants.
Oh, okay.
Yeah, you take it 1 hour before or 4 to 6 hours after you take that medicine. So you have to educate your patient on that.
You said, could you say it again? You said 4 to 6 hours what?
After or 1 hour before, if they're taking like a thyroid hormone medication or a steroid or like a contraceptive, they have to take that within a certain time. It can't be at the same time as
But
that
with the
bowel med-
contraceptive, they need to use a different type of contraception because it's going to decrease the effect of the hormones if it's a hormonal contraceptive.
Oh, wow.
Is that 1 hour before accurate, or is it just?
Yes, it is accurate.
It
This
was
all of
exactly
this
1 hour.
information is on page 834.
Okay.
Okay, let me put 834. I'm glad I asked.
Me too.
That's the medication that reduce the cholesterol, correct?
Yes, ma'am. So you see how I am never just going to sit here and look at you and be like, no, you're wrong. I'm going to help you. I'm going to help you find the answer. Because we remember things better when we find the answer ourselves. Okay? So when I give you key things to look at, it's never going to be the answer to something, but it is going to lead you to the answer.
Okay, so I have one more question within that. So when we were doing the lecture, I vaguely heard something about like the cholestyramine, if I'm saying it right, to mix with water only. But then I think I heard somewhere where it can be, at one point it could be mixed with like the carbonated beverage. So I was kind of confused about that.
I have no idea what you're talking about.
Okay.
I'm sorry. Which should help point you in a direction, by the way. Because I have no idea what you're talking about. I said that me not knowing what you're talking about should point you in a direction that you probably don't need to know it.
Okay.
You have to try not to confuse yourself, because if she's only going to put, like what I be telling myself, if she's only going to put 38 questions on there, which I was surprised because I thought she would have put all 50, honestly, because of like all the stuff we went over. Not complaining, but I just was shocked. But she's not going to ask things that really don't matter. Like, yeah, you should know the stuff, but we only have so much time with her, so she wants to make sure that we know the most important things that we're going to see, things that is going to kill our patient the fastest. So that's what she's going to be looking for, not every sign or symptom or every contradiction. We're not going to be able to remember every piece of that for every single drug. And since she has so little time with us, she's going to be like, okay, do you know the most important thing for this or this or that? Are you going to know how to educate your patient on this or that? Yeah.
No, I understand. I understand that, but I mean, you never know you pointed out some important stuff, but where I'm getting all of this stuff that I had question marks from is actually in the PowerPoint. And I did listen to the lecture a little bit more. It's so long I haven't gotten all the way through it. But every time I leave out something, it end up being on the test. So I want to hit every point, whether I feel like it's gonna be on the test or not.
So what I ended up doing is I went through my notes from the lecture, because I was taking notes during lecture, and anything that she said, like, oh, this is your zebra, or I would make sure you know this, I had that highlighted, and I took all of that along with the key points, and I broke down the key points and added in that stuff to make like a list of pretty much what I'm guessing is going to be on the test. And that's what I use to make this guide for myself.
Right. Because you can't overwhelm yourself. Then you're really going to be like messed up on the test because you're going to know all this stuff that you don't really need to focus on. And then you're going to kind of forget like what you should focus on.
But I do understand what Bonnie's saying because
Yeah, I
she's
have to
feeling
fill in
this
my
way
question
because
marks. I mean,
she's feeling this way because she's been burned in the past. That's why. Also, regarding the number of questions, my bow ties are worth 5 points and select alls are worth partial credit. So that has been an issue in the past of your schooling where those things were not worth partial credit, which is no longer a thing anymore. You can't, we are mimicking the NCLEX. What? Are you okay? Oh, okay.
I was looking for stuff.
Oh, so the point of mimicking the NCLEX, which is most beneficial for you, is giving partial credit for select all that applies, matrix questions, bow ties, and things like that. So I would never give you a 50-point exam with 50 individual questions without having some type of critical thinking aspect, which is where your bow ties and select alls come from. And we are also required to have those next generation questions on your exams, which include matrix questions, select alls, bow ties, priority questions, case study questions. So as you guys progress in this program, especially when you come back to me in complex care 1 and 2, you're going to see even more complex situations with bow ties, case studies. I mean, you could have half of your exam be one case study because it's broken down. Each step of that case study is broken down into a series of questions. So, yeah, having a 50 question, 50-point test wouldn't be beneficial for you and your preparation in the future. What else can I do for you? I like how involved you guys are. It makes me really happy. I've had online groups that were just like quiet as mouses, and I love the interaction. It's really nice. It's okay if you don't have anything else. I can give you an example of a question from a different exam, if that would make you happy.
Yeah, just to see how your questions are kind of set up.
Yes, please.
what did we agree on?
She's going to give us a test question from one of her other exams.
Okay. Did y'all hear me taking care of my daughter the whole time? Because I didn't realize I was unmuted. I do apologize.
You're unmuted, but I didn't hear anything.
Okay.
I'm gonna log off, Miss Simmons. I've officially been up for 24 hours. I worked last night, but I appreciate everything you've done for us.
Please go to bed, and I will send you the recording later.
Thank you. I appreciate you. You have a good night.
You too.
Okay. So this is a question for more of evaluation. So or even falls under assessment. A nurse is reviewing a clinical image of a patient's arm while a blood pressure cuff is being inflated. The nurse observes the arm displaying involuntary muscle spasms and twitching during cuff inflation. This clinical finding is indicative of what electrolyte imbalance? Hypocalcemia, hypercalcemia, hypermagnesemia, or hypernatremia.
Hypocalcemia.
That is correct.
Can you repeat the start of the question again? I'm sorry.
A nurse is reviewing a clinical image of a patient's arm while a blood pressure cuff is being inflated. The nurse observes the arm displaying involuntary muscle spasms and twitching during cuff inflation. This clinical finding is indicative of what electrolyte imbalance? So in the question, you're being told what's happening, who's doing what. So the nurse is looking at a picture, okay? The nurse is looking at a picture of a patient who is displaying a certain adverse effect. And now what is causing that effect?
It's a word for that. The sign, it starts with the T, but that's in like, it's in parathyroidism. I
It's
believe.
called Trousseau's.
The Trousseau's?
Yeah,
Trousseau.
yeah.
Chaustex is the face, the twitching of the face. We'll be going over that. We might be going over that in endocrine, but we're definitely going over it in complex care 1, which is where I'm looking at this test.
Was that imbalance calcium or I get confused with those two? Sorry, that's my refrigerator. I have to get it fixed.
Trousseau's is from hypocalcemia, which is decreased calcium. So there's a thing called Bloom's taxonomy, and it's the way that tests are created, okay? So that means that with you guys being more advanced students, that means that the number of questions that are like those black and white questions where it's like, what is the normal range of heart rate? And it's like 60 to 90, 70 to 150. Like those are questions those are your easy questions, right? Those are your basically I'm giving you a point by asking you the question. When you start in nursing school, you have a lot of those. When you progress in nursing school, that number of questions like that dwindles to a very small amount. Okay? And what takes its place is applying, evaluating, implementing, critical thinking, critical judgment. So the farther you get in these classes and the farther you get when you come back to me is the more complex the situation with your patient and the more it's not so much black and white, but it's how you recognize what's happening, how you treat it, and then how you evaluate. And in pharmacology, it's kind of hard to do that a lot because a lot of pharmacology is black and white, but then also it's knowing the disease process, what it is, what's causing it, and how you fix it with what drug.
Are you done?
Almost.
Oh,
I just stayed over a little bit. What's up? Oh, okay. Um, I don't take class rosters. Michelle does.
Attendance, clinical attendance.
Oh, please. Yes, please. I'm looking for a drug question for my complex care class because I feel like that would help. This could be, it's not a question that you're going to see, but it could be, which documentation indicates the nurse understands how to provide safe care for a patient with a serum potassium of 3.3? Administering a potassium-sparing diuretic to the patient, encouraging the patient to order high potassium foods, restrict the patient's fluid intake, administer intravenous sodium chloride to the patient.
Is it
What was
encouraging the patient to order high potassium food?
Yes. Yes, it is. Because it's very close to being within normal
Because it's
range.
not really that low?
Right. It's very close to being within normal range. Now, just because also I want you to remember, just because a potassium sparing diuretic spares potassium, it doesn't spare all of it. Okay? It doesn't negate the loss of potassium. Does that make sense? So I wouldn't want to give a potassium sparing diuretic to a patient that already has a low potassium. Because if it is going to make it lower. Not significantly, but what's most important is replacing the patient's serum potassium. Is this helpful?
Yeah, it has been.
Okay. Alrighty.
Quick
I gotta go get
question.
some work done. Yeah.
On the keynote, when you said the ROS, do you want us to know the four type of medications, the 4 categories of medications, and like what they do, or are you also talking about knowing like the actual ROS, the mechanism of how the whole ROS system works as well?
All of it.
All of it.
I need you to understand the RAS system. And not only do I need you to understand it right now and for tomorrow, you also need to understand it for the content that we're covering for renal. And also when you come back to me in complex care 1 and 2, I need you to understand what it means and why and how it works. So with what we're doing right now, I'm setting you up for everything that's coming. So for you to understand it now is going to help you be successful in the future. Everything we're doing here, I am literally setting you up for complex care, which is why I love teaching them all three of these classes, because I know what I've taught you, and I know that when you come back to me, I know what to expect because I know I taught you it. Okay. All right, friends. I'm gonna go do more work. Let me know if you need anything.
Thank you. All right. Thank you for everything.
Thank you. Have a good one.
Bye.
So
Thank
hold on, what
you.
time do we log back on tomorrow?
You too. You mean after the exam? Hold on. So lecture is from 11:30 to 2.
11:30. Okay, thank you so much. Bye-bye.
And our exam is 9:30 sharp. Don't
Oh,
be
we
late.
know.
Don't you
I'm
be
gonna
late.
there at 9:23.
Okay. You better. You need more cushion for traffic. You be there at
Okay, I'll be
9:15.
there at 9:15.
9:23 is too late.
Thank you. Good luck, everybody.
All
Bye-bye.
right, goodbye. You're welcome.